Afternoon to all of you, and I'm going to call the meeting to order. I'm going to be serving as chair for the afternoon meeting. And so I'm first going to start by taking attendance and doing roll call. And just a housekeeping item before we go into roll call. If you are not speaking, please remember to keep yourself on mute due to the background noise that we get going through the airwaves. And when we do roll call, we're going to be starting with Jack and myself as chairs first. Then we'll go alphabetical order based on your last name. So please stay at the ready to unmute yourself based on where your last name falls. And you can say present or here or whatever you wish when I call your name. So first, Jack Friedman.
Here.
And here, Kevin Iwanchinna, I am present. Patrick Allen.
I think Pat was going to be a couple minutes late, but he will be joining us later.
Great. Thanks so much. Craig Anderson.
Here.
Catherine Correa.
Here.
Angela Dowling.
I'm here. Thank you.
Thank you. Bill Ely, or Ely, sorry.
Bill said he's having trouble connecting. He's here, but dialing back in.
Thank you so much, Sarah. Jessica Gomez.
Jessica is not available today.
Thank you. Felisa Haggins.
Here.
Ruby Houghton. John McConnell.
Here.
Mark McMullen.
I'm here, thank you.
Bill Olson.
Here.
Jordan Pape.
Here.
Ken Provencher.
Here.
Shannon Saldival.
Here.
Andrew Stolfi.
Here.
And Jennifer Wiellander.
I think Jen was unavailable as well today.
All right, thank you very much, Jeremy. So thank you, Sarah, for sending out all the great notes and our minutes as a review from our August meeting that we had. We just wanted to get the sense of the membership here, whether the summary decisions that were made were correct. Was there anything missing in the document at all? Any edits that we have to make? And if we don't have anything come up, we can have this approved as a consent item, but we want to give the opportunity to the committee to bring up any items that may not have been represented accurately.
This is William. I just keep bringing up, and I just want to make sure, I know we got a little footnote there, but this whole idea of assistance and the allowed, that somehow I would like to see us consider the assistance piece and the impact on the allowed, because I can tell you from our system that's went up 34% in 1 year, and then this year it's going up another 25%. So it does have a significant impact on the allowed.
All right, thank you, William. All right, so we will move on and accept those as a consent. Going through the slides today, if we move to slide 3, we're going to note that the agenda that was created for today was basically a carryover of the September meeting, because we had so much information to try to get through in that September meeting. And we decided to extend the meeting time today by an hour to make sure we had all the time to go through all of these various topics. It's very important to hear from everybody and hear the different perspectives, and ensure that by the end of the meeting that the implementation committee is grounded somewhat in our core principles and what we want to adopt from a value-based perspective. We're going to start with a few updates from the Oregon Health Authority. Then we'll have time for our public comment for 15 minutes. And so those that might be listening in, please send staff a message in the chat if you would like to speak today. We're then next, after public comment, going to continue the conversation about accelerating the value-based payments adoption across the state. Also, we have a draft of the value-based principles that we would like to review. This was updated from the last time that we met. We're also going to revisit the question of, so which payers, which providers and organizations are we really looking at having to report their performance against the cost growth target? And then at the end of the meeting, we're going to be discussing the quality, the equity components, and how we ensure that that cost growth target doesn't harm either of them. Oregon is really a leader in the state when it comes to equity outcomes and health equity. So we want to make sure that we are as aligned as we can be with the Oregon Health Authority and the whole state. So with that, we're going to move next with Jeremy giving us some updates from OHA. Jeremy.
Great, thank you, Kevin, and good to see you all. Hope you're doing well. A couple of quick updates. First, I wanted to let folks know, and you've seen there's a letter in your packet, a letter of support from the governor that we've been invited and have applied to a new technical assistance program that's being funded and run through the Milbank and Peterson Foundations. It's called the Peterson Milbank Program for Sustainable Healthcare Costs. I think as we've talked about over the last year, the concept of cost growth targets has really grown nationally, and there's been a number of states that have been looking at launching something similar to what we're launching. And so we've been invited to apply for basically a 2-year technical assistance program. And while the legislature did fund this bill and a lot of the work, we also recognize that there's a lot more technical assistance use, especially as we keep getting into some of these details that we keep identifying as things that we'll need to continue to hammer out through additional technical advisory groups or more detailed work next year. Also provide us a great opportunity to work with other states as they're launching similar programs and to learn from one another. So haven't been accepted into that, but yet we'll keep you all posted, but really excited for the opportunity to apply, and encourage you to take a look at the governor's letter, which really identifies both how critical this work is for response to COVID, but also a critical strategy for addressing health equity in the state, as we'll talk about later in the agenda. Also wanted to follow up, before COVID, folks may remember we had a conversation around the provider directory, and we are in the process of launching a statewide provider directory through OHA. There's also been some other provider directory efforts out there, including CoMagine, formerly Quality Core, who has a provider directory for some primary care, total cost of care work they do. And we had a takeaway item back in the spring to sit down with CoMagine and see if we could figure out if their provider directory would help give us a boost. We've had a number of great conversations with CoMagine, and they submitted some written testimony as well. The short answer is their provider directory gets us farther along, but is still not totally complete in terms of what we would need to do. They've had it for a really specific purpose of measuring some care at a primary care level, but it doesn't quite capture as much of the attribution as we would need to do. With that said, we think there's a good opportunity to keep working together, that as the state is we're launching our statewide provider directory, that we continue to work with CoMagine and try to find some efficiencies and not duplicate efforts. So I think some short answer is it's not something that's going to sort of completely avoid us needing to have our own statewide provider directory, but we think there's a great opportunity to work together and be more efficient on both sides as we move forward. We'll talk about more of this when we get to value-based payment, but also wanted to share with folks that over the last month or so have had a number of great conversations with Oregon Health Leadership Councils. We've been talking about what's going to be needed to really make value-based payment implementation successful. And I think the takeaway there is there's, I think, acknowledgement that there's a space probably for OHLC to play in terms of supporting this work. Probably not everything, and there's some stuff that maybe OHA would need to lead outside of OHLC, but we're in some active conversations and that I think are going really positively, and think that there's a place there where we could jointly host some work, but a lot more work to be done to flesh out what that might look like. Finally, I just wanted to note the Oregon Health Policy Board met immediately before this, and we had did several presentations updating the policy board on all the work of this committee. And we had a speaker during that, a gentleman named Stan, who's a wheelchair attendant at PDX, who shared really his story around challenges of healthcare costs and choices he's had to make of not being able to afford health insurance, even subsidized health insurance on the marketplace, of having to make decisions about whether he can afford his diabetes treatment or food in a given month. And I just wanted to share that all with you because I think as we get further along in this program, and especially as we get into our conversations this afternoon or around equity, I think it's just important to remember that we've got folks like Stan out there, I think, who are really relying on us to build this thing to really help Oregonians. So happy to share his comments if folks are interested. But thanks.
Thank you, Jeremy. Are there any questions or comments from the group for Jeremy related to OHA updates?
This is Craig. I had a question for Jeremy.
Go ahead.
Thanks. So the provider directory, I'm trying to connect this to some of our earlier work. So is the idea behind this to have a consistent definition of who the primary care providers are so the carriers can align with that and send that information back in?
Yeah, exactly. And Sarah, feel free to jump in here, but this was, I think, it's a conversation we heard earlier in the spring that if we had a statewide provider directory, it would make a lot of the attribution easier. And we will have a statewide provider directory, but we're still in the process of sort of building it out. And so in the meantime, we've got some ideas of how we can do the attribution sort of without the provider directory. Once we have it, it'll be easier for the long run, but that was the issue we were working through in the spring. So, and the short answer, Sarah, correct me because I'm quickly getting it out over my skis here, but the short answer is we're thinking that we would sort of ask plans to do that, to sort of identify providers at the plan level in the first year or two. As we get a provider directory built, we can then have a more robust sort of directory to be able to give plans so there's more consistency.
Any other comments or questions for Jeremy? All right. And to those on the phone, I'm going to be calling out the next slide. We're moving to slide 5, and that's so that you can follow through with your packets as you're joining by phone. This brings us to our time period that's been reserved for public comment. And as a reminder to those speaking for public comment, we have 2 minutes that will be identified per person. I'm going to ask for Sarah and Jen to help identify people that want to give public comment. And we'll ask people to raise their hands or indicate in the chat box that they wish to speak. And for the implementation committee too, there were 2 written comments that were submitted by PEB and OEB boards and also CoMagin, and that was emailed out to us by Sarah. So that is in there for your review as well. So do we have anybody for public comment? Sarah?
Nobody has indicated in the chat yet, but we do have some folks from CoMagin on. Would any of them like to speak to the written comments they submitted?
This is Meredith Roberts. I'm sorry. Okay, let's try that again. This is Meredith Roberts. I'm the Executive Director at CoMagin Health, and yes, we did submit comments yesterday. And I would just like to reiterate what Jeremy supplied already, that we are very willing and prepared to work with OHA in the build of a statewide provider directory. As Jeremy mentioned, our provider directory goes back around 10 years, and it focuses on primary care. We do have OBGYNs included as well. And we're able to attribute providers to practices and patients to providers. So 2 different levels of attribution there. Happy to answer any questions from the committee at another time if appropriate. Thank you.
Thank you very much, Meredith.
I don't think we have anyone from the PEB or OEB boards to speak to their comment, but just double checking.
Yeah, and just to summarize it for folks, if you didn't get a chance to look at it, the chairs and vice chairs submitted comments basically indicating that the principles are aligned with where each board is trying to move, and that they welcome the opportunity to work more broadly with plans and pairs and other markets as we're making this transition to value-based payment.
Thank you for that summary, Jeremy. I'll ask the question just to make sure that we have asked another time. Is anybody else available wishing to make public comment at this time? All right, not seeing any hands raised or anybody identifying themselves. We're going to move on to the next slide. That's slide 6. And at this point in time, really want to kind of start to address the various steps to increase value-based payment adoption in the state. And, you know, I think if you were to poll people in the state, people on our implementation committee on their definition of value-based payments, we are all coming from it with different definitions, different perspective, different lenses. And we also understand that moving from a fee-for-service methodology in healthcare is what we know. I'm putting my physician hat on now. That's the only way I've ever gotten paid for as long as I have been practicing as a physician. And now for me to start to make the move towards value-based payments, it is scary. We have to recognize there's fear based in change. We also recognize that the current fee-for-service methodology is untenable from a financial perspective. We do not get the types of quality outcomes that we get in a fee-for-service methodology. And along with that, that does bring about all of the concepts related to change management. That's really, really important for us as an IC to remember, but then all of our contracted providers and hospitals and health plans, they're gonna have to undergo their own element of change management as well when we go through value-based payments. The other thing that I want to bring up just as a primary care physician and fee-for-service is fee-for-service methodology. We equate it in primary care much as the hamster wheel. There is patients coming in over and over and over. You're trying to do as much as you can do within a condensed time visit, and we submit a charge. And many primary care clinicians at least want to move towards something that is different. We feel that fee-for-service methodology and value-based and hamster wheel medicine has led to clinician burnout. We don't get to spend as much time with our patients anymore. We need the assistance of others on our healthcare team to meet our quality initiatives and to give more comprehensive care to our patients. So many in primary care would like to move towards value-based payments and more of a focus on quality. It's just that fear again of moving from something we know today and moving to something that we really don't know what it will be for our future. The other thing I equate it with is we have one foot on the dock right now, and we want to put another foot in the boat because the boat is the new model. But we're going to have one foot in each for a while until we get comfortable with it and hope that we don't hit the water and fall in. So I just wanted to kind of do a level set on basically value-based payments and the why behind why we're doing this. It is completely stepped in the quadruple aim, which the IHI has come about with. And we have to recognize that with that change does come fear from the organizational perspective and fear individually. So I wanted to thank everybody as well for all the feedback that was provided over the email in between our last meeting and this one. And at this point in time, I'm going to hand it over to Michael to let us proceed with the next steps. Michael?
Thanks, Kevin. Good afternoon, everyone. It's nice to be with you. So taking action is one of the 5 work streams that we've been working through. And within taking action, you all have prioritized value-based payment adoption. So I am going to review over the next few slides where we left things off when we last met in August. And it's been a while, so I want to give you a refresher. So next slide, please, slide 7. So 889 directed this committee to determine both technical assistance and other support to providers and payers to succeed, keeping care at or below the cost growth target. And it also asked that we look at opportunities for lowering costs, including payments, including innovative payment models, and for innovative payment models, including models that do not use a per claim basis for payments. which is why we've talked in our past meetings about both advanced payment models, but also prospective payment models, because 889 pointed to those.
Where do you want to be?
If you could mute yourself, whoever's got it, thank you. Okay, so so just as a reminder, this is what the charge was. It's why we've been spending some time looking at payment models. Next slide, please. So during the last two meetings, you all have expressed strong commitment to advancing, and I would say accelerating, the advancement of value-based payment or system transformation, really to address twin aims in light of COVID-19. One is affordability, which of course was a motivation behind 889 in large part, but also sustainability, which COVID-19 elevated as an issue and priority. And so we've talked about how we might align efforts across public and private markets, and in the private market, including the self-insured market, to bring, as I said, an accelerated pace of change or accelerated rate of adoption of advanced value-based payment models. Next slide, please. At our last meeting in early August, you were supportive of, a set of draft principles that we had put together for you, and the idea of there being a voluntary compact that would follow from the principles once they were finalized. But you also requested some modifications to the principles, which I think was completely expected. You also seem to appreciate that it might be best to have a separate implementation group figure out technical details in terms of how to advance the principles towards implementation. And that would deal with some of the examples you see here of more technical issues to be addressed later on. So all of this has led to a visioning of the process on slide 10. So maybe, hopefully today, we finalize and adopt principles. The next step then would be a convening of stakeholders to finalize a voluntary compact. Jeremy, do you want to talk here about the potential OHLC connection?
Sure, and I'll just say, and we've got several folks from OHLC on, so feel free for folks to jump in here, but I think we've reached out to OHLC, over the last month or two to talk about, a technical group and whether it makes sense for OHA and OHLC to co-host some work together. Where that has led is to a small group of us starting to flesh out and will over the next month or so what potentially more specifically might make sense for OHLC and OHA to consider co-hosting together. By no means is a decision been made that that's the route we'll go, but I think there's been a recognition on both sides, certainly from our side, that they have a lot of payers and providers around the table that are going to be critical for implementing this work, and likewise, I think it is aligned with a lot of work that the OHLC has been doing, such as trying to identify low value care and try to improve value care. So kind of next steps are we're going to have some facilitated conversations over the next month or so and see if we can kind of agree on what the there is. In those early conversations, I'd say we've just thrown ideas against the wall of what this is going to take to implement, and there's a lot there, and so I think there's some more work to figure out, what specifically might make sense for sort of some co-hosted work, what might make more sense to be driven only by OHA, but I'd say just some positive conversations and a lot of interest in trying to create some partnership in this space, but still some more work to come.
Thanks, Jeremy. So so we go from principles to a small group that tries to translate the principles into a compact with an objective as of right now of finalizing the compact and having a broad array of stakeholders sign the compact by the end of the year. That would then be followed by a OHA convened technical group to both help guide and support implementation. So those are the future process steps. I want to bring us back now to the principles because that's really our focus today. And note for you on the next slide, slide 11, that when you reviewed the last draft, you had a bunch of comments. We have identified some of them here, and I want to let you know that we've been attentive to modifying that second version of the principles to try to address some of the issues that you all called out during that meeting. There were, and I should say also subsequent to the meeting, because there were some written comments that came in following the meeting. Some of the issues were really more related to how the principles would be operationalized. And so we didn't address them in the principles. The principles are supposed to, by definition, be a little bit higher order, but we did address others within the modified third draft, which is what you have received. And what we would like to talk about next. So you received a version 3.5, I think just today, that has some new redlining of some new modified language for principles 12 and 13. Other changes that were reflected in version 3, which you received earlier, address some of the feedback that you see on this slide. And so I think if we go to the next slide, please, we'll pause now and invite feedback and comments. Hopefully, at least some of you had an opportunity to view at least version 3 that you received last week.
Michael, before we blow it open to conversation, I just want to hit a couple of the changes in particular. There, some of them were on the last slide, but called out for the fact that these are sort of our visionary goals here, if you will, but that we're obviously going to learn as we go through this over the next couple of years, and called out for similar to the decision you all made around the cost growth target, that there would be a group that would come back together in the next couple of years to revisit learnings, revisit the work from the technical advisory group, decide whether these targets still made sense. And the intent there was to try to keep a stretch goal, but recognize that things are going to evolve over the next couple of years, and that might inform whether the targets are the right targets or not. We called out specifically and apologize for the red line. This was feedback we had actually gotten earlier and forgot to include it in the version 3 that went out, that we really make sure that there's an emphasis on quality. This isn't just cost containment. This is looking for the payment models that are going to both improve quality and outcomes and lower costs, and that the worker and value-based payment shouldn't come at the expense of sort of wage reductions for low-income workers. And then finally, I just call out in 8. We've gone back and forth between prospective payments and prospective budgets, and I think that's something that we'd like some feedback from you all on today. So those are a few additional specific changes.
Thanks, Jeremy. So Michelle, if you are advancing the slides, I'm not sure if it's you. That next one. So I think we want to open the floor and see if people have feedback in general, or if you have any comment specifically with respect to number 8 and whether we're talking prospective payments or prospective budgets or both.
Michael, this is Jordan.
Jordan.
Hi. So I wasn't at the August meeting, so I've been playing a little bit of catch up offline. So I'll add my thoughts in from the third party side. But my personal physician, I pay on a monthly basis. So I'm like Kevin, 1 foot in the boat, 1 foot on the dock. I have experience with this and I feel comfortable. From my time with the CCO in Lane County, I got used to pool funds and risk sharing and how effective that was in driving costs. I would say that my big concern is with transparency of costs. And, we did a recent switch this year to reference-based pricing from the classic TPA self-insurance program with networks. And my big concern in this is that, you know, as you move to a value-based payment program, you lose that reference-based pricing comparability for the services that you're getting. And this year has been extraordinarily enlightening for us as we now see the individual bills and try to negotiate. And we get bills that are oftentimes 4 to 6 times Medicare getting passed through to us, right? And this is the first time we really get to see that. So as you move to a model that is an all-in payment system, if you lose the ability to compare what you've paid versus, you know, the greater region or even the US numbers for those same services, I worry that that kind of opaque process could drive an increase in cost, particularly on the commercial side.
Yeah, that's a great point. And I think it challenges us to think about how to marry VBP with the data use strategy, which is supposed to have lots of transparency about cost, including price, but not limited to price.
So would you see that being married together where you could both see the fee for service comparable charges alongside the VBP all-in payment per life? Or would a physician in a couple of years just submit in their reporting that they had 10,000 lives, or physician group had 10,000 lives at X amount per head?
Yeah. So, I mean, I think it's something we have to figure out. I would also say in the short term, we're likely to see a dramatic expansion of prospective total cost of care payments, because those are the most daunting for both payers and providers to pull off. So when we talk about advanced payment models, they include a prospective budget where there's continued claim payment and then a retrospective reconciliation against the budget. And I think we're still going to see quite a lot of those. I mean, there are providers who aren't even doing that today, for whom that would be a big step. And so I think in the meantime, the OHA analytics team working with employers and providers and payers should think through how do you maintain a sufficient level of price transparency if and when there is a broader move towards truly prospective total cost of care payment. And even then, Jordan, I'm guessing that's never going to happen statewide. It's just not viable everywhere, but it certainly can happen more than it is today.
Would it be appropriate then in our recent red line on value-based payment models or principles for the committee to specifically discuss how to find a level of transparency between the, you know, per capita type model and the specific line item cost for services?
I view it more as a challenge for OHA and stakeholders for the data use strategy. I don't think it's specific to the payment model per se, but I think it's attached to it. That being said, I think it's reasonable to recognize it in the principles, but that's just my opinion. I think others should weigh in and share what they think.
Jordan, this is Jack, if I can weigh in. I think the reason that value-based payment has come up so high in our toolbox is because we think it's the best way to change provider behavior around total cost of care. What you're discussing is really a consumer incentive. It's the idea of sharing information about the various provider costs and fees and trying to influence consumers to go seek their service from a high value provider. So I think we need to do both. And I don't think a prospective payment, whether it's prepaid or budgeted, gets in the way of a data use strategy that puts meaningful information out for consumers to make rational choices as they navigate around the health system. Both of them are necessary if we're going to hit this growth target. And I think we have to be mindful that that we can do both. And I believe that we can. We used to do a lot of prepaid prospective capitation at my old health plan, And at the same time, we tried to educate our consumers about the relative prices in our network. So I think you can do both.
Thanks, Jack. Do others have thoughts on the draft principles? And including in reaction to Jordan's request that there be some acknowledgement of the need for parallel transparency.
Yeah, I have a question. This is Craig. I'm not sure I'm going to comment on what Jordan was talking about in this particular question, but I appreciate the work that was done on Principle 7 and 8. So I think I'd like to hear a little bit more about how you were thinking about that, because the way I read that, it seems to me that 8 is a subset of 7. So for example, 7 talks about advanced value-based payment models, which I would say is a broader category, and then prospective payment is a subset of that. But I want to be clear that
that's right. Accurate? Yeah, that's accurate. 7 is the broader category, and 8 is the more narrowly defined one.
Okay, so what I am having some trouble thinking through is on 8, when we talk about prospective payment, I think technically speaking, if we're talking about a budget model with prospective payment and retrospective reconciliation, does that imply that there'd be upside and downside risk? Because essentially, if you have retrospective payment without any kind of acknowledgement that you're over or under the budget, it doesn't seem to be as stringent as an alternate payment model. So I'm just curious what the thought was behind that.
So going back to our last meeting, at that time when we were talking about advanced value-based payment, we were talking about both budget-based model with retrospective reconciliation that involved both upside and downside risk, and prospective payment. So that's what we were talking about initially as advanced value-based payment models. There has been input from some members of the implementation committee that we should also include arrangements that do not have downside risk. And that's since we last met.
Okay, so if we don't have downside risk, does that fall under, is that really a prospective payment model? Or is that, because it doesn't seem to be.
Yeah, so originally, I mean, this is why Jeremy asked for input on number 8. Originally, what is now number 8 was literally prospective payment. Okay, not prospective budget with reconciliation at the end, but prospective payment. So the question before all of you is, should number 8 be broadened to include prospective budgets with retrospective reconciliation in addition to prospective payment, or not? And if it should be broadened to include those retrospectively reconciled models, should they be upside and downside, or is upside alone also okay?
Okay, that's helpful. And I tend to agree with allowing upside, especially in light of the targets that we've set here, but that helps me understand the difference there.
Okay.
Thanks.
Yeah, thanks for your question.
Mm-hmm.
Michael, I guess this is Ken. I would say that, you know, there are so many subtleties here that get difficult to work through. For example, you could do a low level of upside of prospective payment with just upside, but you've sort of done the downside on the front end. So I wouldn't follow the sword, but my own sense is that to have this work through as many scenarios as possible, less concerned about when payments occur and more about the overall intent of the payments would be my preference.
And when you say, Ken, overall intent, what are you getting at?
I mean, I think what we want is we want, what I think I want is I want to see us move to something that looks like you know, in the direction of capitation that has true upside and downside. But there are many ways to get there, and I'd hate to to shut off different routes that might work better from a cash flow standpoint for some or whatever. So I'd err on the side of flexibility in terms of how it's described.
Okay, but it does sound like you're saying you want to, regardless of whether it's prospective or retrospective or a combination thereof, that you want to see upside and downside in combination.
I do, but
in this
but
number
again,
8,
how that looks might be different. There might
right.
be different ways to get there.
Right. Okay.
This is Felisa. I agree with Ken. I think the more flexibility on this piece, the better. And so I think leaving it open to upside, downside, prospective and retrospective payments. The point is to get to a place where we're doing this. And so whatever this first iteration needs to look like, and maybe we'll learn from that.
Great. Thanks, Felisa.
This is William, I would vote for the flexibility as well. I just think we're going to find groups out there that it's going to be really hard for them at this point in time to take downside risk that have never done this in the past. So I think the flexibility is the right way to go.
Thanks, William. Angela?
Yeah, I was going to also agree with the flexibility component of it. Also, we're looking out for years, I think, to attach ourselves to the goal within 4 years. We really actually should look within the first year and the second year. How is it performing? How are different models performing? So Ken mentioned having some flexibility, taking a look at a broader array of what may be occurring within market and adopting those best practices. But extending out a model for 4 years, it has some risk associated with it. And also we have to take a look at what individuals are willing to consume and buy. So a lot of my customer base is not interested in prospective payments. And we want to make sure that we're serving the communities in which we're serving and providing healthcare in, and making sure that we're providing services and tools and products that they want to purchase as well. So we have to keep that into account. And I'm going to go back a little bit in our conversation, and I agree with Jordan on transparency. Having that information at the fingertips of consumers is incredibly important. They also need to be engaged if we're going to continue to keep healthcare costs down.
Thanks, Angela. All right, so I just want to confirm something, because it sounds like we're making a substantive pivot here. If you happen to have the principles draft in front of you, under the purpose statement in the second paragraph, it defines innovative payment models as advanced value-based payment models, which are defined as payment models with upside and downside risk, as well as prospective payment models. It sounds like from the last 4 or 5 comments that you are interested in redefining advanced payment models to not combining upside and downside risk, but rather to include models with upside risk only, upside and downside risk, and prospective payment models. Is that right? Or is it wrong?
This is Felisa. I believe that that's what Ken outlined, and I think that that change is correct.
Okay, thanks, Felisa. Does anyone disagree?
This is John. I'm still processing that. I'm trying to catch up a little bit. I guess I'm trying to reconcile this with some of the behavior I think we've seen, maybe not so much in Oregon, but in other states, where there was sort of there were these percent targets for some of the HCP land kind of categories, sort of the categories 2A, 2B, 2C. And I think what we saw was contracts that sort of essentially were fee for service with, like, one NCQA or HEDIS quality thing that they gave a little bonus on. And so I just want to be careful about sort of thinking through the implications of loosening that up, because if it sort of creates sort of flexibility, but then also kind of allows for a model that looks a lot like fee for service, but passes the semantic language, then I think that's a loss. So
okay, so John, let me help.
Think on the fly.
Yeah, let me try to help you here. I appreciate it. This is this gets a little weedy. So using the LAN framework, what they call 2C is fee for service payment, where there's a quality incentive bonus. What this conversation is leading to is not including that, but including either budget-based payment arrangements, where at the end of the performance period, there's a reconciliation against the budget. And if the provider came in under budget, then they can share in savings. If they exceeded the budget, there are no implications. As well as arrangements where if the provider comes in under budget, it shares in the savings. If it goes over the budget, it shares in the losses. And it includes prospective payment models where payments are made upfront. And to Ken's point, generally are not reconciled at the end, but could be, and lots of other variations. So we're not, the first two examples that I shared, the budget with the reconciliation at the end, those are still fundamentally fee-for-service payment models, but there is some budget accountability and budget consequences. But they're not pure fee-for-service with just a quality incentive.
Hey, Michael, I just want to, at the risk of confusing this more. So you proposed the definition in the purpose statement, but I think we originally asked folks about the specific the principle number 8, which is about prospective budgets related to primary care and hospitals. And so I wasn't clear if folks were really wanting to go back and broaden the definition for all payments, or if it was really.
Thanks, Jeremy. Right. Number 8 is really specific just to primary care and hospitals. Number 7 was all spending.
And so number 7's definition captures everything that you outlined above, 3B and above. And number 8 says moving specifically to prospective budgets for hospitals and primary care.
Right. Yeah, so I struggle a little bit with prospective budgets because prospective budgets can be LAN 3A, 3B, and 4. So our original intent was number 8 was just going to be prospective payment. So I guess to follow on Jeremy's question, do you want to broaden to shared savings, shared risk, and prospective payment for number 8, which is specific just to primary care and general acute care hospital? I heard you saying yes, but Jeremy's asking for confirmation that you understood that this was only for primary care and general acute care hospital. Is that what you understood, or have we confused you?
So this is Bill. Hopefully y'all can hear me now. I've been having technical difficulties all day. But I guess maybe to dodge the question for a second and ask, are there implications here? So if we want to continue to include or limit number 8 to just be models that have both an upside and downside risk. And then depending on whether you're looking at payments to primary care practices separately in terms of the calc versus general acute care hospitals where you can blend them, what's the likelihood we get to 70% by 2024? Or more specifically, are the size and financial conditions of the PCP practices especially, are there more than 30% of those that just you'll never have on an upside or downside risk? So I'm wondering if just the nature in and of itself of the targets sort of put us into that position where we have to broaden the definition to include both upside and downside or to include upside only contracts as well.
Okay. It sounds like you're saying yes, that we need to.
Saying yes or no and change the targets.
Okay. Okay.
Michael,
So,
this is Catherine, and I would agree with that. I think the targets, if we were just talking, if we were talking upside and downside more advanced, then the targets are outsized in the beginning years. That would be difficult for some to be able to ramp up unless you include upside only, which I don't really see as risk, but I think there's a trade-off between the target size and the model.
okay.
And it would be helpful if we could use the exact language in our document from the land model.
Mhm.
That's very helpful to have category 3B and above or 3A and above. So we are clear about what those two terms mean.
Okay. Okay. So I think where we are right now is number 7, which is about all payments by the voices of at least those who have so far spoken today. That number 7 is 3A and above. And what we're trying to clarify is whether we want to make number 8 3B and above and make the targets less aggressive, or make it 3A and above and leave the targets where they are. Catherine, do you have a preference for 8 in terms of whether we make that 3B with less aggressive targets or 3A and leave the targets where they are?
Well, I would actually make it more complicated in my final preference, and that would be that 2021 is the problem year.
Mm-hmm.
So 2022 and above, I would reduce the targets, but make it 3B and above.
Okay. All right. So let's, I know we're going back and forth on this, but let's focus just on number 8, because I think that's the one we need to resolve. So I want to go back to those of you who are advocating for what was 3A and above, and 3A and above allows for shared risk only. What do you think about Catherine's proposal that we lop off 2021, because there's not a lot of advanced time for that, and make number 8 just 3B and above, which is downside risk or prospective payment?
I like that thinking.
Thanks, Jack.
I can support that.
Yep.
Thanks, Jen.
Does that include changing the targets?
Well, no, we would leave the targets, but drop off 2021. And yeah. Oh, I'm sorry. No, it would regard changing it would require changing the targets. Catherine suggested that if we make it 3B and above, then we would relax the targets for 2022 through 2024.
Yeah, I think that's a fair trade-off.
Agreed.
Okay.
I agree.
Thanks, William. All right. Anybody disagree? I know we haven't decided what we're reducing those targets to.
Yeah, this is Felisa. This is where I have a challenge of sort of just generically saying we're going to reduce targets, when I guess my understanding was that we got to this value-based payment system conversation because most health plans were already on a path towards this and already at a certain level. From the presentation we saw, I'm mixing my meetings now because of COVID days. Every day's the same. But so I guess I just am struggling with, I understand the lopping off 2021, unless it's sort of a base setting year, but reducing the targets moving forward when I thought everyone was on a path towards this is confusing to me.
Yeah, I think the issue is it's not clear that everyone was on a rapid path to doing this for models 3B and above. I think 3A and above is viewed as more achievable, but 3B and above is more challenging. I would suggest that we do not, as a group, try to settle on what the modified percentages would be, but ask the group that's going to work on the compact to take that on as something to work out.
This is Felisa again. So
Yeah,
the group
please.
that's gonna work, the group that's gonna work on the compact, my understanding is the Health Leadership Council. Is that correct?
Jeremy, can you speak to who's going to work on that?
Yeah, no, we haven't quite nailed that down yet. I think there's an interest, but like I said, we are going to work over the next month on what role they want to play in that, if it makes sense. I think the default is if they don't want to be involved in the compact signing itself, then OHA will convene folks.
Okay. So I guess my concern is somebody's not on mute.
Lee, can you mute yourself?
I guess my concern is with the sort of the compact question here, and the target question is there are no consumers on that committee. And when it comes to the Health Leadership Council, and the payers on that group are significantly outnumbered by the industry to set targets there. And I think the whole premise of this is really about cost and changing the payment methodology, not because payers magically want a new payment methodology. It's because we're all committed to reducing costs and meeting the triple aim or the quadruple aim as Kevin would lay out. So I guess my concern with kicking it to another group is how do we ensure, or making sure that this other group has that representation to be as aggressive as we need to be to meet those other aims.
Yeah, that's a fair question. Jeremy, any thoughts on how to structure the composition so that that group has the same spirit that this one does?
Yeah, so there's two things we've been talking about with OHLC, and the reason I'm hedging is because what we're talking about is trying to put together a proposal for the board to consider, and there's a lot of details to work out. So I think there's been positive conversations of yes, OHLC, and I welcome others to jump in who've been in these conversations, have some interest, but we still need to figure out if it makes sense and what that scope would look like. There's two buckets of work we've talked about. One is getting from here to a signed compact later this year. And then the second is ongoing technical work that's going to need to happen over several years to really support value-based payment. And we've been, from state, we've been really clear that we think that getting into the implementation of value-based payment, that we've got to have really clear transparency, a commitment to equity, a commitment to including folks that aren't just payers and providers at the table, including consumer and business and others, to make sure that it's really, there's a lot of trust in the process and that we have that consumer focus. So, I think we haven't established what a table is or what exactly the process is for convening folks to sign the compact.
I hear you on that. But what I just heard from Michael was we're going to reduce our targets and let the group who's delivering the compact decide on what those targets are. I do not. I guess I should be super clear. I don't support that.
Yeah, I was just asking the group that, Felisa. So, I mean, we as a group can work on those percentages right now. I was just, putting that out as an idea. But if you would like to have this group work through the modifications of the number 8 targets, we can do that right now. In fact, I'll invite you to make a proposal.
Sorry, I'm trying to jump around between 2 Zoom screens, so it's hard for me to look at what those targets are. But if we give me a minute, or I think Catherine had the original idea of reduction, so she
I can read them to you.
It'd be good for her.
I can read them to you. So right now, for 2022 through 2024, this would be primary care and general acute care hospitals, land models 3B and above. So it's either upside and downside risk or prospective payment or some hybrid. Right now, they are 40%, 60%, and 70% over the 3-year time period.
I think I would really like to hear from Catherine, because frankly, I feel like what I saw in the presentation 2 meetings ago is that we were close to 20% now. So a 10% increase in 2 years seems reasonable to me, but that did not seem reasonable. And I get that they were not the 3B and above, but I feel like when I saw those presentations, it wasn't clear which percentage was at the land model. And so I'm operating off an assumption that 20% of the current market is at some type of value-based payment. So it'd be good to hear from somebody from the industry, what is a reasonable reduction that they still feel like meets our aggressive goal on these payment models? Because I think I'm making a lot of assumptions based on previous information.
Sure, makes sense. Catherine, can you help?
Sure. So, Felisa, I start with the assumption that 3B and above is the hurdle that we need to get to. And that 3A, while we might have more prevalence of that, it is really the movement towards the more advanced models that will get us to a sustainable and realistic cost growth target. So it's not so much the end point that I disagree with, but I disagree that if we're going, I disagree with having 3A for all 4 years, but I realize the industry needs to ramp up. And that I actually think it's kind of dismissive to say that in 2021 we'll have enough time to go back and redo some contracts that are done for 2021. Given everything that a lot of primary care and hospitals are dealing with. So it's really that the curve starts out slower, but it ultimately in the end years gets us to where we wanted to end up anyway. So I would, I'm throwing this out there. If we lop off 2021, then we start with 25, 50, and 70.
I see. So you're just talking about the adjustment. Okay. Then I think that is, to me, that's reasonable. Lop off 2021 and start at 25, the 50 up to the ramp up. I see what you're saying now. Thanks for clarifying.
Yeah, I think that makes sense, Catherine. I do think it's a little bit more of a steep curve on the end, so I would support that adjustment.
Others want to weigh in?
That makes me feel better too. Thank you.
I guess just to clarify on maybe the starting point, I think there's just, we need to acknowledge there's lots of variability among where payers are, a lot depending on payer mix, right? So if you're a plan like us that has a significant proportion of CCO membership as your base, well, you're already dealing with those requirements and you're building up towards that. If you're Angela and you've got 70% of your business is self-funded, you're starting from a very different place. So I just think we just need to acknowledge that we're not all starting from the same place. And
right.
We need to,
thank you, Ken. Yes, I would agree.
Identify that.
Yeah, it's easy to start. It's the in the commercial market space, it's hard to ramp toward that end, and it varies greatly on your customer mix and who you are serving as a payer.
Okay. And does anyone feel uncomfortable with where we are right now on number 8 and number 7?
Well, I declared earlier I'm uncomfortable simply because who we serve doesn't necessarily fall in line with these, and I've stated that. And Jeremy, I've given you, written comment on that as well. Concerns around it. We are likely able to meet 2 years, but I don't think, based on unless significant changes happen in market from an employer standpoint, the 2 years out may be more challenging.
Okay. Does anyone have comments on any other element of the revised principle?
Well, are we going to add transparency? I know we jumped off when we moved to 7th and 8th, but add a task of transparency.
People comfortable with Jordan's proposal that there be, I think it's parallel and supporting activity through the data use strategy on price transparency. Is that fair?
Yes,
Great.
this is Felisa. I feel strongly about price transparency at every level. I don't necessarily feel like it's 100% consumer choice when it comes to your healthcare, but I do feel strongly that price transparency is critical.
Okay, thanks, Felisa.
I do as well. It's Angela.
Thanks, Angela. Anyone have concerns with the proposal to add something referencing transparency?
William, I would support.
Thanks, William.
I guess I just have to do my normal economist thing and say the evidence on transparency is not super strong, and there's the old concrete example of transparency in some markets leading to higher prices. So having said that, we can move.
Mm-hmm. Yeah. Well, there are questions of how transparency is done, and then as Felisa said, there's transparency for purposes other than consumer choice. I know Jordan's interested in it for consumer choice, but there are other policy reasons for transparency. Okay, anything else on the principles before we wrap up the discussion of potential modifications?
Michael, sorry, this is Sarah. Can we restate the transparency change? Are we adding that as language to an existing principle or adding a new principle?
I think it's a new principle that acknowledges the need for parallel but reinforcing activity data use strategy. Sound right, Jordan? I don't want to put words in your mouth. Okay, so I think we need to make some additional limited but highly substantive modifications to this document. And it sounds like once we've done so, hopefully everyone except noting Angela's continued uncertainty about the out years for the targets will be comfortable. Sarah, it sounds like it would make sense for us to send it out one more time for a look.
No, I'd suggest if we can build it in. I mean, should we either take a 5-minute break, just do a real-time edit, make sure folks are comfortable,
okay,
move forward, and then I think Angela would just like to know how you'd like us to reflect your concerns, if that's just a concern in the report or you want us to reflect the dissent somewhere.
Okay, are people okay with a 5-minute break for us to type up those modifications?
Sounds
Okay.
good. Yeah.
All right, so early break. Sarah, are you going to be able to, or have you already made them?
I have not already made them. I have the document pulled up. Shall we do this live?
Yeah, sure. And if people want to go read their email or go for a walk or whatever, please feel free to do so.
I've started if you want me to pull up the document.
Oh yeah, go for it.
Jen, I'm requesting, I think, control from you, or no, that's not how I do it. Yeah, I need permission for my screen. So Jen, I think I asked for the wrong thing and got control of your screen. Aha, here we go. Thank you. Okay, Principle 8 is we're taking off 2021. You can't tell with the 4. Let me reformat that a little bit better.
And changing that to 25.
25, thank you.
And that's what I heard.
Yep, 25, 50, and then 70.
Yeah,
right?
and then the intro paragraph needs to change because now it's 3B plus.
Did you just scrap preferably prospective budget-based models and just say under advanced value-based payment models, parentheses 3B and up?
Right. I don't think it's preferably though.
Yeah, it's not preferably.
It's not.
Scrap that too.
Oops. Okay. Everybody comfortable with that? I think that's what we agreed to.
Yeah, so for number 7, we need to say advanced payment models.
Yeah, I think that's really going to help because we've been not using the land language consistently.
Yeah, and now in the second paragraph, purpose, we need to expand our definition of advanced value-based payment model to be 3A and up. Otherwise, we've got internal inconsistency.
Okay. So that's made at the top here.
Yeah. Megan, the next sentence says this encompasses payment models with, it should say, upside risk only, comma,
yep.
Yes.
Combined. Then I think we should turn to Jordan's transparency principle.
Okay, that'll be a new one here.
How about, I was going to say implementation of advanced payment models should occur in parallel with public transparency of relative provider price information. May not literally be price, or it might be. We'll have to figure that out. That's just a first stab. Sarah, feel free to edit.
Do we want to specifically call it the link to the data use strategy? Or
yes.
Is the parallel sufficient? Yeah.
In the sustainable healthcare cost growth trends data use strategy?
Yep. I'm just not 100% sure about the relative provider price information. And if that aligns with exactly what we've been saying, I think it's probably close enough.
What if we just said transparency of price?
Yeah. That's better. All right, and I think we're just about at 5 minutes too.
Thanks, Megan.
You're welcome.
That was awesome work.
I'm gonna say.
Thanks, Kevin.
Just save this.
Wait, Megan, pull it back up.
Yeah, I'm just saving it so that I don't lose it, and I didn't want to drive everybody through my files. So just one sec.
Okay, Kevin, if you want to reconvene us, I think we're ready.
All right, everybody, we've had our 5-minute break. Some were watching along during this great transformation of the draft principles by Sarah, Michael, Jeremy, and Megan. Thank you all. We will hand it back over to Michael to walk us through the final edit.
Okay, thank you, Kevin. So I want to note a few things. First, up in the purpose section, we have broadened the definition of advanced value-based payment models to be land categories 3A and higher, which adds upside risk only arrangements, which we didn't have before. And that's consistent with your feedback specific to Principle 7. And then why don't we go down to 7 and 8. Okay, so for number 7, we've clarified now that advanced value-based payment models means land categories 3A and up. And for number 8, we have clarified that we are talking about 3B and up, and we've eliminated the target for 2021, and we've lowered the targets for 2022 and 2023 to the levels that Catherine proposed and that the implementation be supported. Any comments on those modifications before we go to our last one? Okay, Megan, why don't we drop down to the last one? This is the transparency change that Jordan proposed. And it now reads, implementation of an advanced payment model should occur in parallel maybe with public transparency price information implemented in the Sustainable Healthcare Cost Growth Trends data use strategy. So transparency advocates, does that meet your intent?
That works for me.
Thanks, Jordan. Okay, so Jeremy, do you want to see if the group wants to agree on this and how Angela wants to handle her perspective?
Yeah, so I think we, at this point, want to call the question, or can folks live with this? Are you comfortable? I know I can't tell who's just has their video turned off or who is missing. So we may want to actually just do run through and make sure folks are comfortable. But before we do that, let me just ask: does anybody want to identify as not being ready to finalize this or have final concerns?
Jeremy, this is Angela. When did you want me to have comment? I appear to be the odd man out here. Or
I
person.
think anytime you want, and we have the bylaws allow for us to call a vote, and you could vote no. I think we could also just note concerns in the report if you'd like. I think it's your call, Angela.
So I can support 7, and I can support the transparency. I can't support 8.
So I would suggest we just note that in the report.
Okay.
Does that work for folks?
It works for me, if others agree.
Any other concerns?
Jerry, the one thing I guess I would just note, and it is going to impact our ability to hit the target. So, I mean, we're isolating Angela on this issue, but the reality is this is a self-funded issue. And how that really plays with the targets, I think it will be a big implementation issue. So whether we get Angela as a divergent voice on this one item or not, we are still going to have to struggle through this issue as we work through implementation. So we should really note that this is not a minor issue by any stretch, and it will impact the overall ability to hit the targets. self-funded folks are not going to jump into this type of payment both feet forward.
Ken, I think we could take a stab in the report of capturing some of the risks and concerns. I think, you know, Angela's worried about some of the out years. I think other folks are worried about the more immediate years and whether self-insured be ready to go. I think we could capture something along the lines of, and I really think it gets at the principle that you have in here around having this technical implementation committee that's monitoring this, that's bringing recommendations, evaluating whether we can really hit these targets. Well, I think we're not going to know until we get in there and start trying. Does that work, Ken?
Yeah. No, I mean, I can support it, but I just want to really emphasize that the self-funded issue is going to be a big one in terms of really being able to implement.
Yep.
To Ken's point, there's a large portion of the population that is self-funded, and employers don't want to pre-fund claims on a prospective basis. That's why they went self-funded, and other reasons too. But that's what creates the biggest challenge for us. A large portion of my customer base is self-funded. So it's not that we Regents are opposed to the prospective model. It's that our customers won't be purchasing it, and therefore I can't hit these metrics. So there's this interesting dynamic that's in play here, and one that we just have to capture. To Ken's point, other payers who have self-funded employers will also fall into this conundrum as well.
Right. So Angela,
a large portion of those in the state. Sorry,
Angela, do you know what percentage of Oregon is self-funded? So in other words, I'm just trying to get an idea of the magnitude of this problem.
I don't, but I can get that for you.
It's about 25% of the lives.
I'm sorry, Patrick?
It's about 25% of the lives, give or take.
Yeah, I was going to say it's probably 20, 30%.
Okay. And this is William again. Do we believe, I mean, I guess if we can't have some sort of language which moves that book of business more into a value-based, how do you ever resolve then getting to a lower cost of care model?
This is Felisa. I'd just like to jump in here as you know, I think we have members who are in self-funded plans, not, you know, non-self-funded plans, Taft-Hartley trusts. I think people have moved more and more to self-funded plans as a way to control their cost because healthcare is too expensive. It's unpredictable and unreliable. And the industry has, I feel like, frankly, there's a lot of faith lost with payers about that. So I think if we could have a model where it is showing reduced costs and those type of outcomes, I think some of those self-funded plans will be more open to moving towards this. And I agree, and I hear what Angela and Ken are saying. It is hard for self-funded groups to make a leap of faith, or any group to make a leap of faith, given that they've had out of control healthcare spending for the last 2 decades. And so that will be a difficult challenge as part of this.
I would agree with Felisa on that, in that if this does prove to lower healthcare costs long term, then employers will migrate, but they will not be your first adopters. They will be your last adopters. And so there's a prove it to me that it works. Show me what your medical trend spend is look like over the last few years versus in this new model, and there will be an ROI expectation relative to them making movement into this space. So it's not that it can't be done. It's just a delay on their part because they will require proof of the new model.
And I do want to call out, Angela mentioned it though, but I really appreciate Angela, you and your team have been working with us offline, trying to figure out how to make modifications to this and get there. And I think we've captured a lot, even if you can't get all the way there on 8. So I really appreciate your team working through this with us.
Angela, this is Jack. Can I just ask a quick question? I can understand how a self-funded employer doesn't meet our need for a prospective payment model. But if we're going to have a slightly looser definition of value-based to include a budgeted model, maybe where you establish a per member per month target, does that kind of flexibility offer you a path to do value-based in a self-funded environment without having to prospectively pay it? But to
Yeah, so
budget?
that, and I mentioned that earlier, flexibility will be key here. We're going to have to think about different ways of presenting it to them, maybe
Yeah.
a portion of their population, maybe not the whole population. There's a lot of flexibility we could implement here to kind of walk them gently into this process. The other thing to keep in mind is self-funded employers are typically multi-state. So it's not just here in Oregon. They have people in Florida and New York and Ohio and you name it. They're all over the place. And with that, they want to create some level of consistency as well. So that just creates another dynamic.
Yeah,
Again, it's not that it can't be solved. It's just these are some of the challenges that we have to think about, and they're the last adopters to some of this change. Some of them will jump in sooner than others, but you'll find that for the most part, they will observe before they leap. And but if we show proof, tangible proof, lower trend over time, they will start to migrate in that direction. Because as Felisa said, their healthcare wallet is tapped. And so they're looking for ways to lower overall healthcare costs. And if this is one that proves itself out, they will migrate. But again, will be not the first, but probably more likely the last.
Yeah, no, those are great points. I really appreciate your insights. Thank you.
Welcome.
All of this was really important to address and good dialogue from everybody. Jeremy, I'm wondering what are some of the next steps for moving the voluntary compact forward, et cetera? And do we want to start going through slide 14?
Sure. Yep. I think we've given everybody a chance to weigh in. Unless anybody has any final concerns, are we good? All right. So yeah, why don't we go ahead and move to slide 15. Like I said, there's a couple of paths we could go here. One is using OHLC, even if it's a broader group than that table, as a place for a convener. Absent that, I think OHA would be the convener by ourselves and pull folks together. I think the benefit of OHLC is that they have a lot of the senior leaders from a broader set of payers and providers. Even if there's others we need to add to the table. So I think right now, it remains to be seen whether OHLC wants to co-host in that convening folks for the compact. Where hope is that works out. And then, like I said, the second component of that is kind of co-hosting longer term technical assistance. But I think right now we just want to check in and I guess ask if other folks have thoughts on other people who need to make sure they're part of this compact conversation. I would say that from our perspective, we've at least identified, probably some key hospitals in the state that aren't around this table. We've reach out from a couple of about out-of-state insurers that would like to be part of it as well. So I think our goal is to be inclusive of trying to get the major hospital health systems and payer representatives around the table. Whether that's through the OHLC or not. I think question of, should we try to include key labor business consumer reps in the compact as well. I definitely think in the implementation and we're happy to include them in the compact conversation as well. And I think overall next steps are we keep plowing to see if OHLC wants to co-host with us, and if not, then OHA will be the convener. But so I think two questions. One, who else needs to be at the compact conversation, and two, folks comfortable with us continuing to plow forward with OHLC with the backup that OHA will convene if we don't do it jointly.
Thank you, Jeremy. Let's move to the next slide. So the next component of our discussions, we're going to be talking through.
I'm sorry. I'm sorry, Kevin, to interrupt you. Are we answering those questions that Jeremy outlined now, or are we supposed to get back to him later? How does that work?
Yeah, no, I think if we go back a slide for just 1 second, Kevin, I think if folks have feedback on those now, great. And if you don't, then you can certainly email us later. But if you have feedback on who else should be at the table, please chime in.
This is Felisa. I think to get to the self-insured point, you should try to get the 3 largest self-insurers in the state, which they actually are at the OHLC table because they're hospitals, but outside of the hospitals, maybe the 3 next. And then I think you should try for the 3 largest Taft-Hartleys, to Angela's earlier points.
Great, thank you.
This is Angela. To Felisa's point, in the last OHLC meeting, there was a discussion around how this group has consumers, producers, agents, and employers at the table, and we recognize that that also has to be part of the discussion. That's the value and richness of understanding everyone's perspective, making sure that we're meeting their needs, is it would have to be a broader audience. So Felisa, to your point, I would agree with that.
Great, thanks. Any other feedback for us? Going once, going twice. All right, Kevin, I think we're ready to move on then.
All right, thank you. So let's step up to the next slide. They're right there. Thank you. So we're going to go through some of the final details for the cost growth target work stream. And this is where we will discuss which payers, which provider organizations we're really talking about. So for the next slide onwards, I'll hand it back over to Jeremy.
Thanks, Kevin. Meanwhile, one of my 2 computers is frozen, so all my notes are, of course, on the frozen one. So now we're going to transition into talking about which organizations and really the size of organizations that we will include in reporting and measurement, transparency, and accountability at the payer and provider level. I think, as folks know, this slide that you have up right now shows at the payer level, our intent is to collect as much as possible of the entire healthcare spend at the state. And of course, when we get down to the provider level, we then have the challenge of measuring those folks who we can measure total cost of care, and those folks for whom we cannot measure total cost of care. Next slide. Meanwhile, I cannot get to my notes, so I'm winging it. Previously, we had proposed, and Sarah, jump in here if I miss anything. Previously, we had proposed measuring and reporting performance of payers and providers that met a minimum member population size in the aggregate for specific lines of business. We've done a lot of work now to go back and try to identify how much of the market we get or we don't get based off a certain minimum population size. Massachusetts largely, and Michael, correct me if I have this wrong, they've largely drawn the line at sort of an arbitrary number without really a lot of statistical analysis. And we've been trying to go back through and figure out what the size of the population should be as we're looking at it in terms of where we draw the line. So we're going to go over some proposals in terms of where we could draw the line, and you're going to see that we're going to talk about it in a couple different buckets as we've been thinking about it, which is who do we collect the data from, who would we feel comfortable reporting out publicly on whether they met the target or not, and then who would we feel comfortable holding accountable to the target. As I mentioned, the implementation committee, you guys agree that we should go back and look at this from a minimum population size. And so you'll see how the market breaks down by some of the population size. Next slide. Sarah, I think I'm turning it over to you at this point.
All right, thanks. So I guess I want to preface this a little bit with, we did spend a number of months over the summer looking at different ways to conduct that minimum population size analysis. We consulted with some statisticians, we consulted with Massachusetts, we talked a lot with Michael and Megan, and what we found with taking that approach was really that size analysis leads to only including the largest health systems in the state, sort of the known suspects, if you will. And we felt that that approach was just not in line with the intent that we had heard from you all over and over again about wanting to be as inclusive and representative of the state as possible. And so thinking that if we took this strict minimum population size approach that we initially discussed back in February and March, that would really only leave us with sort of reporting on the Kaisers and the Providences of the state. And we thought that that was not where we wanted to land. So we revisited this conversation with the framing that Jeremy outlined. So we broke everything into these three separate buckets, sort of starting very broad and then getting more strict with both our proposal and the statistical criteria that would be applied, so that we have a lot of confidence that we really know that a payer or provider entity has exceeded the target before we would hold them accountable. And every time I'm going to talk in this section about holding accountable, I just want to recognize that I know you have expressed that public transparency is an accountability mechanism in and of itself, but that when I'm saying hold accountable, I mean the accountability conversation that we haven't had yet. So performance improvement plans or other mechanisms that we'll discuss next month. So whatever that sort of stick might be. So our next slide. I'm on slide 19. Our three criteria, or our three buckets for this conversation, we really wanted to align with those values. So for who needs to submit data to the program, who do we want to be reporting in? We want it to be as inclusive as possible per the legislative charge, which says all payers and providers. When we thought about public reporting, we also wanted to reflect those values of transparency and inclusivity. And then we wanted to have that statistical confidence at that very highest level for who's held accountable. And I think there's some valid discussion that we could have about the lines between the publicly reporting transparency and inclusivity with who's held accountable, and then where we are recommending to apply the statistical confidence test. And I think we can definitely talk more about that, but I want to talk through how these three levels work at the payer level first, and then we can talk about applying a similar approach to providers. So you can see all three levels and the sort of increasing granularity, and then come back to this sort of value proposition. So talking about the payers specifically, let's go ahead 2 slides. I want to propose just a general conceptual framework for the payers. So first, we have all payers in the state, or all payers operating in Oregon. Of those, we'd have a subset, ideally most, if not all, payers who meet the criteria for data submission. That data submission would be used to calculate and report the statewide and the market level performance. So we're using that data directly. Then there would likely be a subset of those payers who meet the proposed criteria for public reporting, as in the state would report on those payers by name. They would be identified in whatever the public reporting and transparency looks like. And that would be called out and compared at that insurer level. Not all payers are necessarily going to meet that criteria, especially when we look at line of business. So some sort of drop out. They're in the overall aggregate. We're calculating the data and the performance at the statewide level, but no longer identifying them by name. And then finally, we have a subset of those payers where the accountability mechanisms may or may not apply depending on the results of the statistical testing. So I think what I would like you to take away from this is we do want to include all of the data. It's just, again, who is being called out, or where the transparency kicks in. So next slide, just a quick disclaimer. This is our proposal, our recommendation, but it is preliminary. We've done a lot of proxy analysis. We've looked at a lot of different data sources, including some of the DCBS data, including some of our all-payer claims data as a proxy, but this is preliminary, and we really recommend, hopefully you can have some discussion and we can land this conversation for the recommendations. But based on what we talked about in August, we know we're going to be getting the 2018 and 19 baseline data, and we think that will give us an opportunity to look at the actual data and fine-tune this if needed. So we recognize this is preliminary. All right, next slide actually shows the proposed criteria that we are proposing. So let me do the snapshot here, and then we'll talk about each one of these in more detail. So the first is payers who meet criteria for data submission. So we are proposing that would be all payers and TPAs with at least 1,000 covered Oregon lives across all lines of business. Whenever I'm talking about payers and TPAs for the purposes of this section, I'm also including self-insured payers. We'll talk more about the nuance of self-insured in a few minutes, but definitely know that they're included in this overall bucket of payers. Of those payers, we would then increase the threshold for public reporting to those who have at least 5,000 lives in any line of business. This is a little more similar, if you remember way back to when we talked about some of the thresholds that the other states have set where they have 5,000 or 10,000 lives depending on the line of business. And then for the accountability mechanisms, we're not suggesting an actual population size here. Again, there's not a single value. What we're proposing is based on the results of statistical testing. We would determine whether or not we have confidence in whether or not a payer met or did not meet the target. So you wouldn't necessarily know upfront, sort of from the beginning, if you as a payer or as a provider, when we talk about providers, are accountable immediately. We think we'll be able to build that list and provide a lot of definition around it as soon as we start getting into baseline data. But I know that we had previously talked about, oh, is this payer in or out? Give us the master list of who's included. And this approach would not let us do that initially. We'd have to build that once we start getting into the data. Okay, so next slide, let's talk about our proposal for data submitters. So we looked at the DCBS enrollment data for Q1 of 2020 to see how many payers there are that meet each of these threshold cut points, and the number of carriers in each category and the percent of the covered lives that represents. And so by including our recommendation of at least 1,000 Oregon lives and up, that gives us 86 potential data submitters, which is potentially a lot, but it is pretty representative of the state. We get the majority of covered lives by far. There are 134 characters in that farthest column on the left, but that's less than 1% of the covered Oregon lives, and so we thought that was where the juice wasn't worth the squeeze of trying to pursue data submissions from an extra 134 carriers.
Sarah, can I ask a question at this point?
You can.
So I can't quite read the note at the bottom, but I assume you're using first quarter 2020?
Yes.
Okay, so that's a snapshot of March 31st.
Yes.
And, okay, so when we do a full year, will it be an average, or how will it be end of year, or what would you use?
I think we should put that in the list of technical questions and figure out the best way to do that. I think I don't want to be definitive right now.
No, that's good. Yeah, it's just something to consider, and I don't know that it makes a big difference, but it will throw some carriers in or out because it looks like there's a lot of activity on that low end.
And that's again part of this proposal. Rather than coming back with sort of a master list and saying these payers are definitively in or out, we know that there could be year over year shifting. So say you pick up a new line of business, or you drop a line of business, or you have a major change in your clients, and you could change from above or below this threshold in a given year, and we want to be taking that into account. If a new payer comes in and suddenly starts operating in Oregon and taking up a lot of, starts covering a lot of Oregonians, we would want to be including their costs, and we don't want to set up something that would sort of exclude them by definition from the beginning.
Yeah, and the other thing about this data, and spent a little bit of time in it, is some entities, maybe Pacific Source falls in this category, they're listed multiple times under different entity names because they're, well, I won't pick on one carrier, but some they're listed multiple times based on the structure. So would this be rolled up to a parent organization? Okay.
So yes and no. Let me talk about something on the next slide, but I think this is exactly why I want to be clear that this is based on proxy data, and when we see the actual data from the baseline submission, we might be able to tighten this up. So yeah, there's definitely some noise in this data. Zachary, if you're on, definitely help me out. But on the next slide, sorry.
Going back to, we don't have it right here, but our timeline that we've shown how we're going to kind of ramp this up over the next couple of years. And, when we get 18, 19 data and then 2020 data, And we've sort of called those practice years. And part of the reason is I think we've been able to work through some of these specific questions and figure out how to, because I totally agree with you, Craig. It's a good point. I mean, we get multiple lines of business with sounding very similar but slightly different names of insurers.
Jeremy, what's the mechanism? This is kind of in the weeds, but what's the mechanism for these foreign carriers that have, 4,000 lives in the state or little TPAs to get them to report?
Well, one of the things that you all are supposed to be recommending is measures to ensure compliance with data reporters.
Okay.
Traditionally that looks like fines of some sort. I think there's the reality of when the numbers get so small, it's hard to get those folks' attention, and I think we're trying to draw the line somewhere where it feels like we would be able to get consistent reporters year over year.
Yeah, so I will say that we've had some really good conversations with DCBS about different potential options for some of those data submission compliance or follow-up. We'll talk more about that when we talk about the accountability and governance next month. And confirming that, Craig, you're right, the data are not collapsed in this frame. So there could be we might be counting multiple carriers that are the same carrier, but are essentially operating under different lines from the purposes of DCBS registration. Whether or not that needs to be combined into a single or a separate data submission for the purposes of the cost growth target program is something we will still need to keep discussing as we get into the weeds.
This is Zachary Goldman. If I can just jump in really quickly, these are all great questions and kind of the right conversation we should be having. Just to point out, OHA kind of currently wrestles with some of these questions for the all payer, all claims database in defining which carriers have 5,000 covered lives, and if so, they are then mandatory reporters for APAC for the claims database. So we have some kind of lessons learned in terms of how to navigate some of these questions, but that doesn't mean all of them will be necessarily answered. I think there's some nuances and variations on the theme of different kinds of issues. So just to put that out there.
Okay. So that's the data submission level. Let's move to the next slide to talk about the public reporting level. So again, we're going from the 1,000 lives to submit to 5,000 lives in a line of business. So here is where things start getting a little tighter. We have just a quick example on this table, totally made up payer with Medicare, and just a handful of commercial lives. So this payer theoretically would be named in the report at that insurer reporting level for their Medicare and their Medicaid lines of business, but not for their commercial line of business. The data for their commercial line would be rolled up in the sort of commercial aggregate for the state, but they wouldn't be called out and reported on for their commercial line of business separately. Does that make sense? Okay. I see a couple heads nodding. So that's pretty straightforward, hopefully. Let's go to the next slide and talk about self-insured, which is much less straightforward. So problem one is that there is no one true list of all self-insured payers or employers who are self-insured in Oregon. There's a list of payers that are self-insured that use TPAs. There are 85 of them. And of those 85, 20 of them have 5,000 or more covered lives. And that's the majority of the self-insured market that we know about. There is no known universe of everyone else. There are definitely some self-insured payers who do not use TPAs. So the employer pays the claims directly. They have an in-house processing, and we don't know who they are. So what we would propose, keeping in mind our don't let the perfect be the enemy of the good here, is that we can certainly ask self-insured payers to submit data in accordance with these thresholds, and we'll report on them if they meet these thresholds. But we won't know what reporting compliance will look like. We won't know if we're at 50% compliance, 100% compliance, or something less than that. We can look at our experience with the all payer claims database. We do have some voluntary submitters. They're not mandatory reporters, but they do submit data voluntarily. And we hope that we might see a little bit of that carry over here, where there's benefit in some of the public reporting and the transparency and in informing these conversations. But we just don't know who's all out there, and we would be unlikely to ever get sort of a 100% confidence and 100% compliance in this space just without knowing who they are. Any
Sarah,
thoughts on this?
Hi, this is Jordan. So of the 20 that have 5,000 or more covered lives, do you have any sense that those 5,000 lives are in Oregon, or are these people who reported covering 5,000 lives, they might be headquartered in Oregon, but they're 5,000 lives scattered across the
I believe those are 5,000 Oregon lives, but Zachary, can you confirm?
Hey, this is Zachary. I'd want to look up the specifications of the DCBS enrollment data to give you a solid answer on that. I'm hesitant to speculate. It's a good question.
Okay, other thoughts about the self-insured piece before I move into the third bucket of accountability? Okay, next slide. So again, disclaimer that this is preliminary based on our analysis of proxy data, and once we see some real data for 2018 and 19, we may want to revise this. I also want to note that for accountability, we're talking about accountability at the line of business for each payer's line of business that's publicly reported. So going back to that example 2 slides ago, the Medicare and Medicaid lines of business for that sample payer would go through the statistical testing for accountability purposes, but not their commercial line because it didn't meet the prior threshold. So next. Here's our proposal. There's a lot of words here. Let me talk you through it, and then we have a number of examples that illustrate how this would actually play out. So what we're proposing is that once OHA has calculated performance relative to the cost growth target for each of the payers that meet the previous criteria for public reporting, we would measure the annual growth using a statistical test. And depending on the results of that test, using statistical confidence, that would determine how you shake out for accountability. So in year 1, and we can say year 1 is 2021, looking at the growth between 2020 and 2021. A payer would be held accountable for performance against the cost growth target if they exceeded the cost growth target, and we can detect a difference at 95% confidence. So very significant difference. Likely it'll be fairly straightforward for large payers to reach that confidence level accountable in year 1. If a payer appeared to exceed the target in that first year, but did not reach that level of 95% confidence, no accountability, nothing kicks in year 1. Then we go to year 2, and a payer would be held accountable for performance against the cost growth target in the second year if they appeared to exceed the target, and we can detect a difference at 80% confidence for 2 consecutive years. So you might be a payer in year 1 and you came in at 85% confidence. You were not held accountable in year 1, but if you come in again at 80 or 85% or 95% confidence in year 2, then you have 2 consecutive years, and then accountability would kick in. So you've essentially been on notice in year 1, and we see what happens in year 2. We then started thinking about, well, what are some ways that you might be able to game the system? And what if you front load your costs so that you avoid that 2-year period? So we wanted to have a 5-year look back. So in year 5, we'll say, have any payers exceeded the cost growth target at 80% confidence or greater in 3 out of the 5 years? So some of those might be consecutive, some of them might not be. But at that point, we'd be fairly confident that there were some concerns with cost growth there. And then finally, for any year, any payer who appeared to exceed the target, but we couldn't detect a difference at 80% confidence or higher, there would be no accountability. So we just would be saying we cannot be certain that that this is real, or not that it's real, but that it wasn't driven by the underlying changes or noise in the population or other outliers. So let's talk about a couple of examples on the next slide. This is an example of the 2 consecutive year threshold. So in the first year, this payer does not appear to meet the target, but our statistical confidence was low. It was only 60%, so they would not be held accountable. In year 2, appeared to not meet the target, statistical confidence at 80%, still not accountable because they only have 1 year at 80%. This payer is now essentially on notice, depending on what happens in year 3. And I say on notice, not because I think there's sort of an official come down from the state, you're on notice, but more this payer probably should be paying attention and looking at internal data and thinking about what's happening. And then in year 3, again, appears to not meet the target, coming in at 80% confidence. And this would be the second year of 2 years of accountability, or 2 years at 80% confidence, which would then trigger accountability for year 3. And the reason that we're proposing this sort of 2 consecutive years at 80% or above, when you sort of do all of the math behind the scenes, when you have 80% confidence in 2 consecutive years, that really is equivalent to 93% confidence, which we feel is pretty close to the 95% confidence that we're proposing for that 1-year threshold. Next example.
Sarah, this is Jen. Just a question.
Yeah.
You may have said this. Are you also proposing that you use the statistical confidence to ensure that someone did meet the target?
Yes, I'll talk about that in a second.
Okay.
Yeah, so, okay,
I think it's just want to call it, I think it's a good point that this part of this program this isn't just about identifying who's above the target. I think we also want to think about how do we identify, who's below the target as well.
Yes. Okay, so the example for payer 2 on the next slide. Payer 2 appears to exceed the target in the first year at 95% confidence. They are held accountable for year 1. Straightforward. In year 2, they also appear to exceed the target. Our statistical confidence is lower at 80%, but that still meets that threshold of 2 consecutive years at 80% or above. They are also held accountable in year 2. And then they do better and meet the target in all remaining years. In example 3, we have a payer who meets the target initially, then does not meet the target at 80% confidence, meets the target again in year 3, does not meet the target in year 4 at 80% confidence, but that's not 2 consecutive years, so we don't trigger accountability in year 4. But then in year 5, they fail to meet the target again. We tested 80% confidence, and now accountability is triggered on essentially 2 counts. They have 2 years of 80% confidence in year 4 and year 5, and they also hit that 5-year look back. In 3 out of the 5 years, they have exceeded the target at 80% confidence or greater. So this is sort of our safeguard. And then finally, example 4, we have a payer who does not appear to meet the target in any of the 5 years, but we have low statistical confidence for all of those years, and so we do not hold this payer accountable at all. So, okay, yeah, next slide. Just a little bit more of the rationale for why we're proposing this in this way. So, while this program is an annual program and we want to measure and report annually, for some of the smaller payers, and definitely when we talk about the smaller provider organizations with the same approach, we need multiple years to be certain that that payer or provider really is exceeding the cost growth target. As I mentioned, that sort of on notice concept, if a payer exceeds the target in that 80 to 94% confidence range in year 1 or any year, they know that they might be subject to accountability mechanisms in the next year depending on their performance. And then making sure that we're avoiding creating any perverse incentives that might manipulate maybe front loading of costs or setting up contracts in a way that would ensure you're sort of skipping that 2 consecutive year threshold. So next slide, to your point about high performers and ensuring that meeting the target is real also, we would do the same thing for payers who appear to have met the target to ensure confidence in strong performance. So what this would actually look like in terms of public reporting after all of the statistical analysis has been applied, we would have 3 broad buckets. We'd have payers that we knew met the target and we had statistical confidence in that. We have payers that we know did not meet the target and we have statistical confidence in that based on any of those tiered structures we just talked through. And then we'd have payers in the middle that we don't know with any statistical certainty how they did. So sort of the full range of what we're willing to, I guess, commit to. And I want to stop there and see if there are any questions about how the tiered accountability approach would work and any initial reactions to that.
Sarah, this is Ken. Thanks a lot. I want to pick up on Jen's question. It feels to me there's a an opportunity for some framing around this that is less about whether they met or exceeded the target, but more around whether we consider their data to be valid. You know, it puts less emphasis on who are we trying to catch.
Yeah, so
Really
I'm gonna probably say this wrong, but let me try and then Zachary can correct me. I think we are going to be, the payers will submit the data. It is your own data. We are making some assumptions that that data will be accurate and complete, and we'll go through some validation and check all of those things out. But the data are what the data are. And so if we say your costs were X in year 1 and Y in year 2, that's real. It's not that the data aren't real and aren't valid. It's just whether or not there was enough variation or noise in the data. So I want to be really careful about that distinction. Like, the data are real, and we're not including because the data are somehow fake or not valid. It's whether or not we think you can be held to the standard of accountability because of considerations outside of your control.
Sarah, this is Michael. Could I add something?
Please.
Ken, in other states that have cost growth targets, where we've assisted them, we've been creating pretty rigorous processes to validate the data that are reported by the payers without actually auditing it, but by applying some algorithms to assess whether the figures seem credible, whether they're credible in relationship to one another by service category relative to other payers. So there is some level of validation that goes on before payers' data are accepted. And even as rough as this seems, we have found multiple examples of payers that have submitted data that clearly are wrong. And we can tell it that just by looking at PMPM values by major service categories.
And all of this proposal for reporting and accountability is after, it's post-validation. We've already gotten to a point where the data have been cleaned, any back and forth with the payers have been addressed.
Yeah, excuse my terminology. It's been a couple of years since I've been in a stat class. I wasn't necessarily referring to validity in the pure sense, but more, I mean, what we're really saying is, do we have confidence is there enough there and enough variability in the data that we think it's
exactly
reliable? So I don't know. I just wonder if there's a way to frame it so it's not just about those that, and I know you caught it on both ends, but I wonder if it can be framed together. Not a big deal.
And I think you're totally right, Ken. There's a lot around the messaging of this that we have to figure out. I think I was probably a little heavy-handed in this section about meet the target, not meet the target, because I want to be really clear about who we're talking about, because it all sort of filters down through. I think in terms of how this is reported and communicated publicly, we definitely have a lot of development on the right message.
So Sarah, William, I had a question, and maybe you've already answered it a little bit. And I was having trouble understanding, how do you get a 60%, an 80%, or a 95% confidence if people are submitting the data to you? But maybe you've answered that, and that you can tell right away.
The data are what the data are. So the payers submit the data, we go through the validation process, we say, it appears that your per capita expenditures in 2020 were this, your per capita expenditures in year 2 were this, and then we will apply a test, like a t-test or another statistical test, and we would look at the resulting confidence intervals of that. So we're not actually testing the amounts. We're not testing the confidence that the amounts are what they are. That is what it is. The data have been reported. Total healthcare expenditures in 2021 were what they were. It's just whether or not we can detect a difference between the 2 years.
So let me build on these questions as well, and maybe I'd try to rephrase it, at least as I'm capturing this, is you're going to have some sort of statistical measure that basically tells you whether, in essence, there's enough volume between years to make sure that changes in the cost is not due to random statistical variation.
Yes.
Which brings up sort of an additional question, and you mentioned it earlier in passing, and I just want to make sure, where we talked about data noise, but also underlying changes of the population. So if I'm a, whatever, 10,000 life entity, and year over year, my costs go up 20%, let's say, and that's largely driven by my claims in excess of $2 million having increased. Is the purpose of the statistical test to just look at random variations, which you could argue a $2 million claim is sort of random? Or is it getting into the causality of we can determine underlying reimbursement or cost on an apples and apples basis year over year as well?
Yeah, totally. So let me clarify something I totally skipped over. Again, assuming this is after the data have been submitted, they're validated, we're all in agreement that these are the data we're working with. The data that the payers will submit is going to be risk adjusted. We talked about that several months ago. The data will already be risk adjusted, which will account for a lot of what you're talking about before we get to this step. Any other questions about how we think this might work?
I don't have a question. This is Felisa. Oh, go ahead.
I guess I have a couple questions, but mostly just want to, I guess I'm more interested in offering, or sort of, I can imagine a couple ways where it's like, I just sort of write down a couple counter examples. Well, what if this happens or this happens? And it seems like there's a few things you want to kind of work out through the numbers. And so I guess my two questions are, one, I guess for Michael, like, what do other states do around this? And then two, like, is there going to be, if there's a subgroup or you want to sort of do some technical side thing, I'd be happy to devote some time to that. I don't think it's worth gaming out everything with 60 people on the call, but there are, I just imagine a couple things that, seems right, and then you find out that there's sort of some goofy counterexamples that don't work the way you want them to.
Yeah, John, I think we're looking for feedback on kind of conceptually, are we headed in the right direction, but definitely would I think include this in sort of a technical advisory group ongoing as we get deeper and deeper into it, as well as needing to actually work through validation with the carriers as the data's coming in and make sure this approach still makes sense. But I think, and Michael could jump in on the other states, but I think if it's not obvious, I think the large challenge that we're having to deal with and why we're trying to kind of be creative in the approach here is the way we're different from the states that have implemented this so far is that we have more carriers spread out, and so sort of some smaller population issues. So I don't think they've gone through the 1 year to 2 years, or 2 out of 3 years, or 3 out of 5. And I think we're trying to figure out a way to make sure that that we aren't just sort of cutting out a large part of the market and trying to come up with a different way to think about this.
And let me just push on that a little bit then. So I guess then is this really about? So I guess so a lot of this comes about variability, and so I guess I'm thinking of, like, let's imagine a really small payer, and they've got some super small number of patients, and the average in year 1 is $500 per patient, and then the average in year 2 is $1,000 per patient. I mean, to a certain extent, like that. Like the PMPM doubled. You can do some statistics and you can sort of put some confidence intervals around there, but essentially they're paying twice as much. And so is the goal here to sort of not penalize them because they've got a couple of big outliers that they couldn't have controlled, or is it something else? And so how do we think about? I mean, I think, like, I'm pretty comfortable thinking about means and variability and stuff like that, but I'm struggling a little bit to sort of understand, like, I mean, I get this conceptually, but I just want to make sure, like, what does it mean if you've got somebody who's small and every year it kind of goes up and up and up? What are we trying to protect them from by this sort of confidence interval thing? So it's not just a small n thing, I think, right?
There is the small end thing, and that's real. And obviously a carrier or a provider entity with many more lives, it'll be, they'll have narrower confidence intervals, and so you would see that. So I think there's a couple of things in response. Like, one is, John, what you're saying is exactly why we've sort of separated out this reporting from the accountability piece. because it's important to know that if you're a smaller payer or provider, you're doubling PMPM or PMPY in a given period. I think it's important to know that, and we want to be able to look at that. But whether or not that is driven by outliers and you're should then be accountable for that. We had previously had some discussion about whether or not we should truncate outliers in this program. Certainly, that's pretty common when you're measuring total costs. You can sort of set a threshold and you'll say, all right, if you've got a really expensive patient or member, more than $1 million a year, we're just going to take them out of the data. And we didn't think that that was the right approach for this, because we really want to look at what's actually happening and what costs really are. And so we've decided not to truncate outliers. And so because of that, this is almost a counterbalance.
Okay.
So this is Felisa. I feel like I think I understand the point about like a sort of stepped up approach overall. I feel like I would say I really appreciate this. I think we haven't gotten to what is the accountability conversation. And I think that when you say accountability, I think often people jump to worst case scenario, when what accountability could mean is, let's take a look at your data, figure out what the problem is, and figure out if it was in your control, help you control what you can control, and move forward. That is an equitably acceptable form of accountability to some large fine or punishment or something like that. So I think having done the CCO rounds of work and setting up the CCOs, I think this really clear on the front end, what is the expectations that you're going to be measured against is incredibly critical. And I think this outline of like, here's the different ways that you're going to be measured against this for accountability, I think is really important. And I think you've done really good work here.
And I do recognize that it is hard to have this conversation when we don't know what the accountability piece is and that we haven't landed that. I think all we've talked about so far is we want a spectrum of options, and to your point, absolutely, this process does include reviewing the data, understanding what's happening, and determining whether or not that was the justifiable or unjustifiable increase. And that happens as part of that too, because so again, I totally skipped over all of that detail in this outline, but we go through this whole process, we test, we have very high confidence that your cost growth exceeded the target, but was it a justifiable reason? Was there a new drug that hit the market? Did something else major change? That is also part of this program framework. It's not just the results of the statistical analysis.
I think it's probably worth noting that it's important to have some rigor and criteria here like you're doing, and I think that's great stuff. This is ultimately not the folks that are going to move the dial, right? This we're staying this at kind of that bottom end of critical mass. They're not those are not the entities that are ultimately going to make the difference. So I think applying the rigor is important and saying who's in the pool and then moving on.
So maybe next slide for any broad discussion about this whole package, not just the accountability piece. We're essentially proposing the same approach for provider organizations. There's some nuance again about which provider we're talking about and how specialty might factor in that we want to address with a technical group, but for the sake of time, we have generally the same proposal for providers, with the exception that providers don't submit data, only payers submit data. So do we want to do a broader discussion of this whole proposal?
Yes, Sarah, this is Craig, and I just want to tie the provider to the payer question. And first, I just want to confirm at the payer, is it done at the payer level, which would combine Medicare, commercial, and Medicaid?
The payer would report separate lines of business, so separate rows in the data file for the provider that they're reporting on.
Yes, but is the test at a combined level or for each of those levels?
No, the test is separate. Zachary, Stephen, did I say that right?
Well, we would be measuring whether or not a pair was above the target or below the target by line of business. I think I think a question we haven't nailed down yet is a pair held accountable if they're above the target in any line of business, or is that an average? Or I think that's part of what we probably get into more next month is when, what are the triggers for accountability, but we'd at least be measuring on a, the reporting would be triggered and we'd be measuring at a line of business level.
Yeah,
and
I think that
we're
makes
reporting provider line of business as well.
Okay. And then on the provider side, as I recall, each carrier was submitting, like you said, carriers submit the provider information. And my memory of that was that we weren't then aggregating at a provider level between, you're laughing, I mean.
So we've been talking about that. That was something the committee asked us to investigate back in the spring. And we have been looking at ways that we would be able to aggregate the data. So say multiple payers report for the same provider, and we aggregate at the provider level to have a more robust picture of their commercial data. I can't guarantee that we can do that because we don't have the real data submission to test it out, but we've been working on that and we think that it's possible. We've been learning a lot from the provider directory work about identifying providers and making sure that you're talking about the same provider organization. And so we think it will be possible to submit the data in a way that would allow us to combine across providers at some point in the future.
Okay, good. I think that's going to be critical to get the numbers you need and have it be what you want. Thanks.
Sarah, I think it might be valuable just to quickly at least show what the thresholds are on the provider side, just so we get a feel for.
Yeah, can we jump to slide 41, Jen? Yep, this one, thank you. So providers would not submit data. We're proposing 10,000 unique all payer lives or 5,000 lives for any one line of business for the public reporting, and then the same tiered accountability process, again, at the line of business level.
But this assumes that you would be aggregating.
Yeah, it does. It does. And I think if we get the 2018 and 19 data and find out that our plan for being able to do that is not sufficient, then we'd have to revisit that, because these thresholds would mean we would be unlikely to be able to report on very many entities.
Sarah, Jack here. When we combine lines of business, Medicare, Medicaid, and commercial, each of those has a different reimbursement rate and disease burden and all that. So we'll be sure that there will be some adjustments made so that providers with heavy Medicaid versus ones with heavy commercial, there'll be some way of acknowledging those structural differences, yes?
Yes, I think, not to get super back into the statistical weeds, but when we were talking about this internally, yes, absolutely, reimbursement rates are different, prices are different, and if you try to aggregate it all together, it's not going to be reflective of anything appropriate. So what we were talking about is an approach that would let you combine the cost growth per line of business. So you say, okay, you increase by 2% for Medicare, 3% for Medicaid, 5% for commercial, and then we do a weighted average of the growth increase, not of the actual reimbursement or per capita expenditures.
Great, perfect. Thank you so much.
And Sarah, I'm sorry, last question. I assume this is based on both provider assignment and attribution models?
Part of the way that we're structuring this, again, because Oregon doesn't have sort of the full provider directory, it won't look like the way Massachusetts is doing this. We will rely on the payers who are reporting the data on their providers to know who they're attributing. So we'll have the technical group define some of the criteria, but then each payer will apply that. So if you have a clear contract with attribution lines internally, then that's pretty straightforward. And we had talked about whether or not we could have sort of a single attribution model statewide, and I think we're not there yet.
They're all lousy.
And then
So
another question, back to the data reporting, and maybe this is more for the payers. How your systems have the ability to take, say, surplus payments or something that are part of value-based contracts and attribute them down to the member level in this type of reporting? How does that?
Are you asking the other payers that?
Or anyone? Because as we move to value, there's going to be more and more of these payments that potentially are not like attributable to Jen getting care at St. Charles. And so I'm trying to figure out how those play into.
But as a payer, wouldn't you know that you paid out X in quality bonus or in reconciled, APMs to that specific provider? So you might not know exactly based on the attribution or sort of the individual level claim line, how you paid that, but you'd still know how much the provider received overall.
Yeah, you'd know how much the provider got, but then on the provider side, if you're attributing lives, you're going to have these payments that the payers know they made to, say, St. Charles, but which lives then are you going to hold me accountable for and associating those payments with it? It feels like there's
I think I think this needs some more work with the technical group for sure. So thank you for flagging it. I think the easy answer is probably something like you just per capita it out, and we're not actually trying to attach it to a specific individual. But I think we need to do more work on that.
I mean, I think the short answer, Jen, is, and Michael will be curious if this has come up with our states, is the payer is going to be aggregating all the payments by a line of business to a provider and dividing it by the number of members. So I would imagine the claims and the non-claims payments together and then dividing it by number of members.
Yeah, they'll break down the service categories, Jen, and then have a separate category for non-claims based payment.
So I guess this is Bill in terms of sort of another flag, if you will, for the technical group. And I've been trying to, I don't want to drag anyone down a rabbit hole and just keep the good discussion going. But as an entity that's both provider and health plan, there's some complexity on these views at the line of business level. There's some complexity on the views at sort of the accountability level. In short, the business is managed as an integrated delivery system. So I think the proposed criteria for holding responsible for an integrated delivery system shouldn't split between provider versus health plan. But just as you recognize that, in some of the other states' models, they don't have large integrated delivery systems in place. So there's just some nuances we need to figure out of how to bring that component into these measures.
I agree. That's a good technical conversation to get into, and that's a real thing we'll have to work through.
So I know we're a few minutes over time, and we kind of browsed through the provider piece, but I think our overall question is this directionally correct, and do folks have feedback or major concerns? And I know we've sort of gotten into that, but I think it's probably maybe we should just transition to that conversation and take a read from folks and have broader group of folks weigh in.
Jeremy, I want to weigh in on John's question of me a long time ago. How does this compare to other states? And I would say it's way more thoughtful, and it is better than what any other state is doing, in my opinion.
No surprise.
You're just trying to make us feel good about ourselves.
No, I'm just obsessively honest, and that's how I feel.
Anybody else have thoughts?
So outside of some of the other work that the technical group was going to look at, I feel I'm in favor of the general proposals that have been put forth for the both the providers and the payers.
This is Felisa. I agree with Kevin on this, and I also think I just want to point out that this is such a critical part of how to get this to work, that it's not just a payer question or just a provider question, which I think was part of the reason how we got to this solution rather than the original proposal. So I'm excited to see how this moves forward.
I'd flag just one other issue for the technical group to think about, is maybe as a lot of the data flows through in attribution models, we'll end up with a lot of unattributed care. And we need to really think about how that really relates back to these providers who are only getting stuff attributed to them that relates to sort of the care that happened versus the care that didn't happen. So it's just one of those little technical things that is not unimportant.
Thank you.
This is Jen. I would say this seems like really great work and thoughtful. I'm just trying to connect all the dots in my mind about how complicated this may seem to people outside of it. And once things get complicated, how do we ensure that providers and payers can understand it enough that they know how to take action on it? And I know that that's further down the road, but we're only going to make headway if we understand things enough to change our behaviors and our members' behaviors and our practices. And so I just wanted to name that this is, that we can't lose that as the quest.
Thank you, Jan. I appreciate that comment. And I am also, I'm also a little bit concerned about, I think Sarah, you said, what the penalties might be. And we live in a world where people pretty much figure out how to skirt those things. And so, I don't want people withholding care or putting off things so that the numbers look right. So I'm just trying to figure that out in my head as we go through this, but it looks good to me, the novice eye. But I do want to ask those questions as we move along, because I want to make sure that we've not designed a system that allows people then to withhold care along the way in order to make the numbers look good.
Yeah, thanks, Ruby. I think, and that's a perfect segue into the rest of our afternoon conversation in a little bit here around measuring quality and inequities.
Any other final comments before we think of taking a well-deserved break? All right, what I'm going to ask the group, if everybody would oblige with doing a 10-minute break instead of a 15-minute break. Serve your bio needs, clear your head, go and get a drink of water, and if I could ask the group to reconvene at the time of 3:40.
Good job, Sarah.
Thank you for being so diligent with our timings, and also just a lot of the good questions and advice and information that you're giving back to the committee. We're going to start off by doing our equity and equality and equity work stream. And if we want to go to the next slide. Next slide will show just this conversation about the need to look and address equity, because quality and equity cannot be separated. Also a reminder to the group that equity does not mean the same thing as equality. Equity is where you give additional and more enhanced resources to subpopulations that are not meeting their health outcome when you compare to other major populations. We see this over and over again in healthcare, where people of color are dying at increased rates from maternal morbidity and mortality. We see increased post-surgical complications with people of color. And it's really, really important to address social equity, racial equity, health equity when we are having our quality conversations. Next slide. This is a reminder to the group that we were directed to ensure that we were looking at the quality of care and aligning approaches for measuring quality by the Health Plan Quality Metrics Committee. And Governor Brown, in her address back to us, wanted to ensure that there was a focus on inequities and reducing disparities of care. So again, we can't separate the need for health quality away from inequities of care. Also, I love living in our state because the state of Oregon did put together the 2020 to 2024 State Health Improvement Plan, and it's titled Healthier Together Oregon. And equity and social justice is actually the very first value that was listed in this State Health Improvement Plan over the next 4 years. So the work we're doing here is very well aligned with the State Health Improvement Plan. Next slide, and we'll turn it over to Jeremy.
Great, thanks, Kevin. when we first started talking about this program a couple of years ago, there was a task force, as folks may remember, that originally looked at a variety of different models and ultimately landed at recommending this program. And among that discussion, and many of you were a part of it, was making sure that we didn't lose focus of quality, or that we would put quality at risk as we're trying to contain costs. And I think that sort of evolved into making sure that that we're measuring and don't have unintended consequences that exacerbate inequities. And we're going to talk about both of those two first things today, quality and equities. But I think as we've been thinking about this, especially over the summer, have really moved to also thinking about how do we use this as a program that actually helps improve equity as well, and what would be the things that we want to measure. So I think there's a difference between sort of measuring inequities or making sure things don't get worse for certain populations versus what do we actually need to be able to do to improve equity. And we've been thinking about this from a few different perspectives as we go through the next couple of slides. I mean, certainly there's the affordability issue, and we've got some data on challenges there. But we also know that we're in a tough budget situation. We know that healthcare costs continue to outpace wage growth, continue to outpace the state general fund budget growth, and that makes it more difficult for the legislature to make investments and programs that specifically will address inequities and structural racism, things outside of healthcare, such as social determinants of health or wages or housing, education. And we also know that in order to address inequities, we also need to be making investments within the healthcare system and parts of the system that will really improve health. Thinking about making sure we're investing in the right resources in primary care, behavioral health, and prevention and population health, and culturally responsive care, community health, things of that nature. And so, sort of at multiple levels, there's issues of costs impacting creating inequities, but also impacting the ability for the state to address them. And so, want to think kind of broadly about the intersection of cost and equity. We really don't see those as two separate things. We see cost containment as really a core strategy as part of addressing equity, and the governor spoke to that in her letter to the Peterson Milbank. Next slide. We see in health insurance survey data, just as an example, that certain populations and people of color face larger inequities as it relates to the impact of affordability on healthcare. And so you can see sort of this reflects a percentage of Oregonians who report delaying care because of cost. And you can see wild swings based off of different populations. You know, the Native Hawaiian Pacific Islander population, almost 1 in 4 reported delaying care in the last year as a result of the cost of that care. Next slide. Massachusetts, as an example, as they've been operating their program, have been breaking down affordability as part of reporting on healthcare cost growth, and they've been able to show things like that there's a higher cost burden on families who are non-white or are based off sort of education, and so they've sort of tried to break down and try to be able to provide some information on how healthcare is part of some other larger social inequities that you see in the state. Next slide. So as I sort of already hit on, we see sort of 3 buckets to today's conversation that Michael and Megan will lead us through. One is, broadly, how do we measure quality, and what are the types of quality measures that are important to keep an eye on as we're trying to contain costs? But secondly, how do we monitor for unintended consequences? How do we make sure that we aren't exacerbating existing inequities in the system? And then third, what are the things we want to measure so we can have future policy conversations around what do we need to do in the state to actually improve equity, especially as it relates to costs? So there's some overlap between these, but we think overall there's some important connections, but there's also some distinct different buckets. So with that, let me turn it back to Michael.
Thanks, Jeremy. So I'm going to walk through the 3 strategy concepts. These are ideas that we're inviting you to respond to. You can certainly, and you will be invited to consider other ideas, but these are the 3 that are most fully developed for today's conversation. Next slide. So the first of the three strategies is the idea that there would be public reporting on a standard set of quality measures, so that the public reporting of performance against cost growth target would be done in parallel with attention to quality measures. And in this case, the quality measures could include equity measures or disparity measures, as the case might be. As with the cost growth target, the measurement would occur at multiple levels, as Sarah has been talking about before, and would be shared not just in the report, but also potentially in public hearings. Next slide, please. There is some experience in other states with cost growth targets of reporting on quality. Massachusetts has done so. They used to have a measure set that they reported from. Since then, they've reported not on that measure set anymore because they've moved to a new measure set, but to some other measures of quality. Delaware actually established healthcare quality benchmarks at the same time they developed their cost growth target. So those are reported annually at varying levels, sometimes just at the state level, because sometimes their quality benchmarks are really population health measures, and sometimes at insurer and provider levels as well. And you can see some examples here of the measures that they've included in their quality benchmarks. And finally, Connecticut, actually not quite finally, Connecticut is in the process of developing healthcare quality benchmarks to implement in January of 2022. It's going to be 1 year after they do their cost growth target, but it's also viewed as being bringing a parallel focus to quality along with cost. And then I'll note that the leadership in Rhode Island is expressing interest in having them begin to consider quality. They started purposefully by just looking at cost, but now there's talk about beyond. Next slide gives you a couple of examples of existing public reporting on quality. So for the Oregon Health Plan, there's reporting at the CCO and state level on quality measures, especially those that are CCO incentive measures. There's actually excellent reporting that's done annually. And for PEB and OEB, there's state level reporting be done, not at the carrier level. And in neither case is there any reporting at the large provider level. And to translate these measures, or frankly any measures, from insurer level measures to provider level measures takes a little bit of work. It's doable, but it does take a little bit of work. So that's the context of what's being done elsewhere as well as within Oregon. Now I want to share with you a straw proposal and then invite your feedback. Next slide, please. So the proposal is that the Health Plan Quality Metrics Committee, which is another committee that reports to the Oregon Health Policy Board, be tasked with identifying a subset of its current endorsed health plan measure set. You can see a link to that measure set at the bottom during 2021. The Health Plan Quality Metrics set, Health Plan Quality Metrics Committee's measure set is right now used as the universe of measures that can be used for incentive purposes in CCO and PEB and OEB carrier contracts. That measure set's pretty large. It's 55 measures for 2021. And the proposal here is that the Health Plan Quality Metrics Committee, maybe with some assistance should it need it for thinking about provider level application of measures, would identify a recommended subset of that 55 measure set. And performance could be reported in parallel with what's going to be done with the cost growth target, which, just as a reminder, for the first year, it's going to be statewide and market level, and then moving to health plan and provider organization level, or it could include health plan level, since, as I noted on the prior slide, there's already some health plan level reporting that's going on. So let me finally just give you a little bit of a feel for that Health Plan Quality Metrics Committee measure set. Of the 55 measures, about a little under half of them are prevention and early detection measures. And then 15 are for chronic disease and special needs, 5 are for acute care or procedural care, 4 patient access and experience, 2 system integration, and 2 cost and efficiency. So this is the first of the 3 strategy proposals. Next slide, please. And so I'd like to pause and invite questions and reactions.
And I just would add, Michael, the legislation Assembly 89 calls specifically for the committee to think about how to align with the Health Plan Quality Metrics Committee. And so I think the short answer here is the recommendation for aligning is to choose measures that have already been selected by that committee to kind of work out the process.
Thanks, Jeremy.
This is Lisa. I feel like the alignment across this is really critical for providers. And so I think the more alignment, the better. So this seems like right track, and I support this.
Can I make a quick comment?
Please.
I think for the reason Felisa just mentioned, I think this makes sense. I do think it's important to at least point out that the metric infrastructure between HPQMC and metrics and scoring has really struggled with the issue of metrics that are specifically aimed at equity outright. And so I think as we sit today, we're really looking at proxy measures that might contribute to equity. But I think this is yet another reason that we really need those committees to lean in on how to measure equity explicitly, which is something they've been anywhere from ambivalent to outright hostile to doing so far.
Thank you, Pat. That was my question. How does this square with the governor's new stand on equity? Having sat through a number of the electeds and BIPOC community leader meetings, I recognize that sometimes we lay things out on paper and they look good, but they don't apply. So I just appreciate Pat saying that and putting it on the table honestly, because I think in order to address equity, we, or the state, jointly, all of us really need to do more work.
Yeah, there are 2 measures currently in that 55 measure set that could perhaps be viewed as equity measures. I will say in that.
Can I?
Yeah, go ahead.
Sorry, Michael. I really, this is like, as Pat knows, this has been my soapbox for several years, and it's hard for me not to be super angry about it. But what I will say is, I think all of these measures could and should relate to equitable outcomes for communities of color, and they should be broken down by that. And so there are 2 specific measures that maybe call out equity, but within every single one of these measures, we can see how our system is either succeeding or failing communities of color in our state, and we should be explicit and measurable about that. And I know that that is a comment for the Equity Committee and the Metrics Committees. And I think to Pat's point, how they change so that they can hear that more clearly I'm very interested in that topic.
Yes, so Felisa, I'll note that in other states that are applying measurement to equity, their focus, and this has not been the Health Plan Quality Metrics Committee's focus thus far, but their focus has been to take measures in their existing measure set and identify where there are race, ethnicity, and or language disparities among subpopulations. And so there is the potential to stratify, many, if not all, of the measures in the measure set in order to identify where disparities exist. I do know that within the HPQMC there, and within OHA, there's been discussion about distinguishing disparity measures from equity measures. But I will share that in other states, they are focusing on trying to identify where disparities exist and then use that as the basis for trying to improve quality where gaps are most significant.
Yeah, and to be clear, in the health authority, we do that stratification in the measures that we use to actually manage the organization. It's at this level of these metrics and how they're applied that I think we got a lot of work to do yet.
This is Kevin. I wanted to tag on with what Felisa was saying, and I definitely agree with the need to look at our various quality metrics broken out by populations and people of color and compare to other populations, and then develop very strategic and prioritized approaches to improve those quality outcomes in our people of color. The only way to do this is to ensure that providers and clinics all are very adept at getting real data into their EMRs, because the only way that you can do your data analysis is by having that real data, race, ethnicity, language, disabilities, in your EMR, so you can then extrapolate that information based on your clinical quality outcomes.
Yeah, I'll note, Kevin, I think it has to be parallel activity. It's both doing measurement with what you have today and building a foundation for way more robust measurement in the future by building out that infrastructure. So we've focused on a topic within this broader one. Any other reactions?
I have just a quick question, more on logistics. I really like the metrics that will be reported are a subset of existing metrics, but I believe that the existing metrics are they're not reported for all lines of business. I don't believe. Are there any concerns on the payer's ability to report these same standardized metrics for all lines of business, or is there time lag that the committee needs to think about in when that required reporting would start? So kind of two questions, and just curious, I don't know the answers.
So some of them wouldn't be applicable to all lines of business. I mean, for example, if there are measures that are prenatal care, probably wouldn't apply to your Medicare Advantage line of business, for example.
But broadly, I mean.
Yeah, and there are some measures in the measure set that are really specific to Medicaid that wouldn't make sense for commercial or for Medicare. So if we sort of winnow those out and look at measures that would fit, broadly, at least across Medicaid and commercial populations, some of them would be much easier to apply administratively across lines of business, and some of them would be more challenging. And I think that has to be part of the conversation about what are the administrative implications of doing so. And as I noted earlier, Jen, what are the administrative implications of applying them at the provider level?
And I'd also add that many of these metrics are already adopted within the National Quality Forum, NQF, that have set the standards, and NCQA, so that plans that are NCQA certified have already been reporting on at least some of these HPQMC metrics.
There's always a balance when it comes to quality measurement between what's easiest to measure and report and what's most important to measure and report. And if the HPQMC takes on this challenge, they will have to wrestle with that. Other reactions?
I have a question about just the reporting on this. Would it also come through the payers? Do you think that's the natural, like the claims, they would come through that way?
I mean, at least in part, Craig. I mean, the question is, and frankly, that's the easier part. If it was a payer claims-based measure that, or even a payer non-claims-based measure, let's say that's already being reported to NCQA, that's an easy one. I think the greater operational challenge will be the provider level measures that aren't already being routinely generated and reported. I know that in Delaware, for example, the measures that are not population health measures that sort of come from HRSA, the clinical quality measures, they are gathering all the values from NCQA's quality compass data, and they're not even requiring the payers to report them. They're just going to NCQA for them. So to the extent that they are HEDIS measures, then that's easy. To the extent they're not HEDIS measures, it becomes more complicated.
Yeah, I could see that. And then I think I agree with the earlier comments about then slicing the data by different populations for the equity issue. But again, if it's coming through the payers, that information has to also flow through for consistency. So I think that's just something that
right. It's hard. So typically it's easier for Medicaid to stratify by RELD. That's for everyone on the phone in case you don't know, race, ethnicity, language, and disability status. But it's much harder to do for commercial and Medicare Advantage populations because insurers do not universally collect that information or collect it the same way, at least in other states. I don't know about in Oregon. So this is a not insignificant piece of work for the HPQMC to take on. And it may be that at least initially the measures are not identical for all lines of business because it won't be possible to do it the same way, even when there are measures that are theoretically applicable across lines. So with all of those warnings, are people still comfortable with trying to pursue this strategy? I didn't mean to cast a dark cloud.
Yeah, it's William. I would vote in favor of. I think it's critically important.
Thanks,
I agree with William. This is Catherine. It's a subset is great of something that is already there, and then we'll improve it as needed.
Thanks, Catherine.
Also from the provider side, if our providers are already used to doing this because of the CCO incentive metrics, it's better adoption for the other lines of business that they are seeing in their clinics.
You know, Kevin, your comment makes me think that when we're talking about a subset, it's probably not a subset of the 55. It's probably a subset of the measures that are being used by CCOs and OEB and PEB.
Right.
Right? Because if they picked one of the 55 that's not being used by either of those payers, then it's not going to help providers.
Agree. Alignment with the CCO metrics as much as possible would be advantageous from the clinical perspective.
Yeah. Okay. Anybody have concerns? Okay. So next slide, please. Just an invitation. Does anybody want to weigh in on domain or domains or prioritization for quality measures? And if you just want to defer this to the HPQMC, that's fine, but we wanted to give you an opportunity to weigh in if you felt strong. I think we've already heard interest in equity and disparities, so I'll note that.
I would also like to flag for folks prevention and early detection, particularly because as people age, it's critically important that we focus on those things so that we don't get runaway trains. And I would add that having to do with health disparities and people who put off care.
Thanks, Ruby.
This is Kevin here. I didn't want to disagree with Ruby, and I think prevention, early detection is so important from a healthcare outcome perspective. Having said that, the costs that are decreased from that prevention and early detection are often out many years, and they might not be realized in that annual analysis. I would put a vote in for acute, episodic, and procedural care. And often I see that there is increased costs occurring because there is not true integration and communication between the entities providing acute care, episodic care, procedural care. And that communication path that follows the patient or follows the member could be vastly improved upon.
Thanks, Kevin.
I agree with that, Kevin.
Any other opinions or preferences? Okay, why don't we go to the second proposed strategy of the three on the next slide, please. And this is monitoring for unintended consequences from the cost growth target. So experience in Massachusetts does not indicate that there have been unintended adverse consequences since they implemented it in 2013. That's based on a combination of anecdotal reporting and tracking utilization patterns of certain services that might have been sensitive to it. But I'll also say I don't think Massachusetts has taken a really rigorous approach to looking at this, and I just don't think there's been a lot of sensitivity to it in the state. Clearly, there's at least potential that both provider and payer organizations could take actions to impede access to needed care to meet the cost growth target. It doesn't mean it would happen, but it's at least theoretically possible. And so that's why we're suggesting this as the second strategy. Slide 57, please. The Health Equity Committee has expressed interest in this direction. I will note that in Connecticut, there's been lots of attention to this. The Consumer Advocacy Committee has been very energized about Connecticut developing a monitoring strategy for its new cost growth target pre-implementation. And in fact, their advisory committees will be reviewing potential measures this fall in advance of the effective date of their cost growth target, which, like Oregon, is 1/1/21. The next slide has some examples of potential measures that could be used to look at unintended consequences. Next slide, please. So the first example is a patient survey question. This is from the CAP survey, asking individuals if they were able to get care that they needed during evenings, weekends, and holidays. Those are times where a provider could stint on care by not extending access. Certainly preventive care services is an area where access could be impeded. And then there are some broad service access utilization measures that could be considered. This is not the universe of possibilities. I just want to give you a sense of what some of the options might be. When looking at monitoring for unintended consequences, we are proposing, next slide please, that whatever measures are used would be stratified by populations in order to detect subpopulations where there might be adverse consequences that would not necessarily be picked up in aggregate data. So these are 5 examples of potential stratification. It is certainly easier to do stratification of some measures more than others, I will note. But for some of the types of measures that I just shared a couple slides earlier, this should be possible. If you could press, it's not next slide, but next bullet on this slide. So the measures would be calculated for unintended consequences at state, insurer, and provider entity levels longitudinally, starting in 2018, and Jeremy talked earlier about our practice run of calculation. So we're going to start the practice run with 2018 and 2019. And this would allow us to have a baseline that would be somewhat non-COVID stable, so that when we are post-COVID, we'll have a reference point that will feel a little bit more reliable than what 2020 will be, and perhaps 2021 as well. Next slide. So the proposed process for doing this would be to have the Health Policy Board, the Health Equity Committee, and again, the Health Plan Quality Metrics Committee work in 2021 to develop a plan and specifically identify a small measure set for monitoring unintended consequences. There could be an advisory group formed by these three bodies that could also bring in broader consumer representation, because ultimately we are talking about adverse consequences for consumers with these measures.
Michael, this is Felisa. Can I, on this potential process in these groups, I think I'd like to, if we could add DCBS to this, because DCBS does do the insurance and access, and they do that survey every year, and so they could look. And I think a large portion of people of color are disproportionately in Medicaid, but also disproportionately in the exchange, which DCBS oversees.
Great, thanks, Felisa. Okay, next slide, please.
Michael, quick
Kevin.
comment just about how we would define access. So if we're looking at the pre-COVID measurement time of 2018, 2019, we know that current COVID and post-COVID, our definition of access might be different than what it was before. Only because many groups now are doing a lot of telemedicine and phone visits, and that is still treating the patient. So I would just ask the question, how we would define access.
Sure.
Many patients still think of access as a face-to-face in the clinic, and many of the clinics and hospitals have evolved past that.
Right. Yeah. Well, I know NCQA has added telemedicine codes into their measure set.
Yep.
So I'm sure that would be a consideration. Ultimately, it would be, potentially this new advisory body or work group that would have to wrestle with it. My personal suggestion to them whenever they form would be to think, where is their greatest risk that would be posed to service access if there's an entity that's saying, boy, I got to make sure I stay underneath the cost growth target so that Sarah's methodology for testing me doesn't kick me out. And so I think there needs to be some consideration to where could things go awry, and make sure that we're taking our temperature there at those most vulnerable points and for those most vulnerable populations.
Thank you.
Okay, so what do you all think about developing a specific strategy for monitoring for unintended consequences? Does the general both approach and process that I described and amended by Felisa make sense? And should there be monitoring for unintended consequences? I guess that's a more fundamental question.
I think that there should be monitoring for unintended consequences. This is Felisa again, sorry. I think there should be monitoring for unintended consequences across the sort of for patients. I also think there should be monitoring for the workforce as well. If we're just, I think this goes back to the VBA principles earlier, if we're just cutting wages and benefits for the lowest paid workers to try to move this needle, or, dialing back on staffing, which eventually could hurt quality, like what does that look like? So some sort of monitoring of the working conditions of healthcare workers as well.
Okay, thanks for that suggestion.
Michael, this is Jordan. When I was involved with the local CCO, there were providers who would just not accept the CCO or not provide services to members of the CCO. So walk me through how measuring the unintended consequences would play out as you came across provider networks that didn't engage with the CCO.
Yeah, if I think, Jordan, about how could this theoretically go wrong, it's probably not so much that it's going to be providers who are not participating in the CCO doing anything. In fact, they're probably least likely to do anything because they're not going to be held accountable to the cost growth target because they're going to be too small. It's the entities that are going to be held accountable, which is going to be larger groups, IPAs, health systems, as well as insurers. But I would say probably the greatest concern would be with provider organizations that would say, hey, we have to make sure that we take steps to stay under the cost growth target. And so how are we going to change access to care to restrict our cost growth?
Well, maybe let me ask this a different way. So there is the flexibility amongst large provider groups to not contract with a CCO based on payment terms. And Patrick, maybe you can help clarify some of what I'm asking here, but there's the ability to not engage. So here you have CCOs who might disproportionately be serving communities that we're trying to specifically pick up here.
Yeah. I would say in the short term, there's probably no impact because the CCOs are already subject to a 3.4% cost growth requirement through OHA's waiver arrangement with CMS, which is the exact same amount as our cost growth target. So I would say short term, the rules of engagement don't change for them.
Go ahead, Michael, sorry.
Yeah, if in 5 years the value drops down, which is what you've recommended, and becomes lower, then maybe. But I would think that from the perspective of a provider organization contracting with a CCO, the cost growth target doesn't change things for them.
I was just going to add, there still will be network adequacy standards that will apply to CCOs and commercial plans. But I think on the next slide, we've got some things we can be measuring, like patient experience and access. And it seems like those, if those are impacted, you sort of start to see the patient saying they're struggling to get access. And then the next question down might be, well, why? And maybe then it's, well, we're having some contract issues, but maybe sort of dissecting what's driving some of those other things that we're measuring.
Yeah, this is John.
Go ahead, John.
Just to build on Felicia's comment, one thing that I think you could monitor to pick up on this is sort of understanding how the composition, and I think you have to adjust a little bit for the uninsured population, but sort of holding that constant, how the composition of the population has changed between the Medicaid and the commercial group, because I think if and I'm not exactly sure how providers or payers can do this, but if the concern was that patients with more medical complexity would be more expensive and there were some selection issues, maybe there's potential to sort of have, on the margin shift those to the Medicaid payers who have sort of set administrative prices, where then kind of the commercial population, they can still hit their access measures, but they've done that by not by changing care, but sort of by some subtle selection things. And so that's probably pretty easy to monitor to build in.
Thanks, John. So as Jeremy was referencing, here are some examples of ways to try to pick up unintended consequences. So I'll go back. I asked a little bit earlier, are people supportive of developing a detection strategy, early detection strategy to pick up unintended consequences? And you can see here, we've got examples that are patient experience, but we also got Lisa's idea of impact on the workforce, and also looking at actions that employers might take to reduce benefits. Now, I'm sorry, that insurers would take. It wouldn't be employers, it'd be insurers would take.
Well, I think it makes sense to measure unintended consequences. I still am wondering, once you get down to measuring at a provider level access to underserved communities, how they might be impacted between two larger organizations negotiating over a CCO contract, even though the growth rates are the same. I think once you start to measure at a provider level, you might see some of those unintended consequences pop up.
Yeah. Yeah, well, I think, Jordan, your point speaks to the fact that after that Costco target's implemented, it would probably be worthwhile to do a little qualitative research, which might be formal or informal, and talk with people about what's happening on the ground. Because even with the most thoughtful of planning to try to anticipate what will happen, it's possible that there will be other repercussions that weren't anticipated. Okay, so I'm going to take silence to mean that people are okay with this. So why don't we go to the third and last of the three proposed strategies. And this is more equity focused. So the idea here is to focus analysis on variation in utilization and cost across populations. So we've talked primarily about whether people are accessing and getting certain services, but we haven't talked about looking at how spending varies by subpopulation. And so we could consider the following questions and use them as the basis to inform improvement activity. So Jen, if you could press the next. So here are some analytic questions that could be asked and that could be built into the data use strategy. And by asking these questions and observing differences, there would be the opportunity to address where there may be impediments to equity. And I want to share with you an example on the next slide. So Jen, if you could go forward to, yeah, one more. So Minnesota did an analysis of utilization and spending for its home and community-based services waiver programs, which are a rich array of services. And they found that the population receiving those services was much less racially diverse than their less comprehensive personal care system. They had no idea until they looked at spending and utilization by racial category. And so specifically, next please, they found 60% of people getting personal care assistance were people of color or Native American, and that compared to only 14 and 27% in other disability waiver programs that they had. So as a result of this, next please, they instituted a pretty comprehensive study to look at institutional biases that exist, and they're trying to identify and implement promising practices to improve their eligibility assessment process. So this is using analysis of service use and spending to identify where there is lack of equity and then taking action to improve equity. And so this third strategy here is using data to inform action to improve equity. Next slide, please. So what are your thoughts on this?
This is Felisa jumping in here. I feel giddy about this because I do think that there is, I often think about this at some of the redirection of the spending that we've done in other areas and the potential on like primary care homes and looking at the spending on primary care and looking at the cost share analysis and who has plans with higher cost share. I just feel jazzed. I think this is a great approach. Thanks for bringing it forward.
Great, thank you.
And this is William, you know, as I look at this as well, I mean, this is really the long-term way of reducing healthcare costs. So I'm very supportive.
Thanks, William.
Yeah, I would agree with William. Yeah, I'd rather do this than the unintended consequences if I had a choice of how to spend our money.
Mm-hmm.
I think we would get more for this than we would for the other.
Mm-hmm.
Catherine, I agree with that. I second.
Okay, that's helpful to hear. So that might provide some guidance in terms of allocation of resources. I don't think it necessarily means don't do any unintended consequences, but maybe devote more here and less there relatively. Is that right?
Where do we have higher or evidence that we have risk on unintended consequences versus what this is more on is broader and going it completes our sense of equity as well, not just the couple of measures we have in the data set, but really speaks to outcomes around equity.
Mm-hmm. Thanks, Catherine. Anybody else? Okay.
Looks good, thank you.
Thanks, Ruby. Okay, so we have a next slide has a few additional bullets, 2 ideas, and then an open invitation. So these were not proposals that we put before you, but we just note them as additional options. The first would be to pursue opportunities that would both support cost growth attainment and improve quality and equity. And here are some examples right here, reducing low value care or avoidable complications for acute services. That has positive implications in multiple directions. The second idea would be to, after the data use strategy has been implemented, convene provider collaboratives to act upon opportunities that are revealed through the analysis. So there may be some opportunities that are systemic and not specific to individual organizations, and where collaboration might be a way to speed and systematize improvement where an opportunity exists. And then finally, we just want to invite other ideas that you might have beyond those that we've suggested today.
This is Kevin here. Just in terms of additional strategy number 1, it might be important for the implementation committee to just state they support groups in Oregon that are already looking at the reduction of the incidence of low value care. And I bring up the collaboration that OHA and OHLC did in putting together the low value care report. Now, the next question is, how do plans and systems and providers all work together to operationalize the low value care report that was developed already? So I see us more maybe in a supporting role rather than needing to implement this additional strategy.
Thanks, Kevin. Are people feeling 3.5 hours of meetings? Is that what's going on?
Yeah. Well, I support what Kevin said. This is Catherine.
Thanks, Catherine.
I do as well, and maybe this is Bill, tackling one of the other ones. I think it's probably useful. It sounds like there's already some information around the low value care. But to sort of size these in terms of how deep is the well of potential. And, you know, I'm not familiar, you know, with other payers in the market and the programs they have. But, you know, I think the potentially avoidable acute care, I think by and large has been worked fairly extensively by the industry over the last few years. So I'm not sure how much more there is there. So I would maybe deprioritize that one depending on what the data said versus some of the other ones.
Thank you. Jack, were you going to say something?
I think.
I'm sorry, go ahead. Ruby, is that you?
This is Felisa. I think that on these, you know, additional strategies, I can't think of any off the top of my head right now, but I do feel like one of the things that I thought was very successful in the CCO implementation was the learning collaboratives, and how do we set up and think about how we let all flowers bloom to help with the issues around maintaining costs as well as quality across the markets. And I think that that should be, what we didn't do is really have an equity lens or a race ethnicity focus on that, and or gender affirming care focus. And so is there a place where that CCO transformation, the commercial payers and providers get pulled into that conversation to make these improvements? I don't know if that was clear.
This is Kevin. Felisa, I like what you're saying. I do feel that being one of the providers that participated in the CCO Provider Collaborators, there was a great opportunity to share best practices. And if we, again, could assist in convening of those provider collaboratives, or at least ensure that they're being done to some degree, I think it'd be great. Also, speaking from the CCO perspective, in CCO 2.0, our deliverable with the OHA was to ensure that contracted clinicians, and that means behavioral health, physical health, and dental health providers, were all trained in equity and inclusion aspects. We have to develop an equity and inclusion plan and then go forward and train our contracted clinicians.
Yeah, I mean, I think as we're moving to broader metric alignment across markets, you know, I think that really helps with taking the transformation center from just a CCO focus into a broader focus. I mean, we're trying to get all markets to make movement on some of these metrics. So I definitely think there's an opportunity there, Felisa.
All right, Jeremy, I think I'm ready to hand it back to you. Jen, maybe we could advance a couple of slides.
Well, I think first of all, we hammered through a lot today. I'm kind of surprised that we're actually ahead from where we were an hour and a half ago. But this is, I know this was an intense day, and we got an incredible amount of feedback from you all. I think we have 2 meetings left. Actually, Jen can go forward one more slide up there. We have 2 meetings left right now, November 24th and December 16th. I think we also recognize that it seems like whenever we get to about the middle of November, somehow the rest of the year disappears, despite thinking that there's a lot to get done. So we do have 2 meetings left before finalizing the report. I do think it's an open question of, can we really get through all the accountability piece, which is sort of one of our last big buckets to get through. So I think it would be good to take a good quick temperature check on whether folks think we should try to schedule in an additional meeting just in case. We recognize the accountability piece was probably going to be one of the tougher conversations, and purposely we're sort of saving it for the end, but we also want to give it justice. So I think that's one last question that we have before we adjourn today. Or would you guys prefer just to leave it to Jack and Kevin to make that call?
I was just going to state that I think it's always wise to have an additional meeting just in case, if we felt that we had that time allotted, but we wrapped it up in less time. That's always great.
Are you thinking an early November meeting, Jeremy? Something along those lines?
Yeah, I think given that we've got 5-6 weeks till the November meeting, probably something in early November. We don't have to decide the date now, but probably something between now and the November meeting.
Yeah. Earlier in November, I think the better. And these are pretty important conversations. So it's nice to have the conversation in one meeting and then have to take it up again.
Yeah.
Okay, great. Well, we will work with our chairs and staff and try to schedule something in. Michael, Megan, Sarah, anything I'm missing?
I want to just confirm that I didn't hear anything from committee members in the discussion on quality and equity that we need to specifically bring back to the next meeting. Is that correct, or is there sort of an outstanding question there? I feel like we got really clear direction, but I just want to make sure we're not leaving anything hanging.
Yeah, my general sense, and maybe why that component of the meeting went so much quicker than the first component, is that when it comes to healthcare in Oregon, so many of the players in the healthcare arena are already very invested in equity and inclusion, and we're not in disagreement.
All right. Well then, Kevin, I think you get the great job of getting everybody 22 minutes back.
All right. Well, this was a team effort. This was a really robust discussion today. And when you look at all of our deliverables that we actually achieved, kudos to the whole group. Michael, Megan, thank you as well for working overtime during that 5-minute break and getting our language of our priorities done straight away. And we will try to look at some dates for an early November meeting, and stay tuned.
Yeah. Thank you, Kevin, Michael, everyone.
Thank you.
Thanks, everybody. Take care.
Bye, everyone.